Check one, check two, check three, check four. Check one, check two, check three. Yeah, live at 5:30, 4:30. All right, thanks so much. Bye.
go ahead and get started as people are settling in. Can you all hear me? Oh, that now it works. Okay. I'm calling to order our meeting of the Justice Fiscal Advisory Committee for Monday, August 28th. The first item on our agenda is the adoption of said agenda. And I wanted to just make one addition to the agenda. We have another speaker who will be joining us, and that is Mark DeLong from Amethyst House. So if we could just put him on that list, we'll just put him at the bottom there. We have a lot of people presenting today, which is super awesome, but will require a little bit of time management on my part. So in the interest of moving things along, does anyone else have any changes to the agenda? Yes.
I just wanted to clarify that you're putting Mr. DeLong, who's from Amethyst House, at the bottom of number 5 and not on the bottom of the entire agenda, correct?
Hello, there we go. Yes. Goodness, it's not a good start. Any other changes? All right, all in favor of this agenda, say aye.
Aye.
A song. The next item is number 3, recap of discussion on diversity, equity, and inclusion. I thought had a good meeting talking about the various ways in which people are included or could be included. And I want to turn it over to my esteemed colleagues for sharing any recommendations that they might have taken from our discussion.
Did you have any?
No, again, I thought it was a really good meeting. And for those who haven't had a chance to look at the NAACP study, to go ahead and do so and read it. It's very enlightening.
If you look on page 2 of today's agenda, I tried to gather as many of the fiscal recommendations that I could from that conversation. And of the 4 bullet points, we're already doing all 4 in some capacity or another. That doesn't mean that we don't need to, a member of our public just held up their single page of the agenda in the packet on page 2, excuse me. Maybe we can get some of those printed out. Anyway, the DEI recommendations from last time were gather more data, examine justice system processes for implicit biases, fund diversity training for county staff, and designate individuals from Monroe County government to work closely with the NAACP to analyze data. That seems a little sparse to me. It seems like we could be doing more. If you have ideas, suggestions, please email those into the county court, the county council office, and we will also be working on that as well before our final meeting.
Thank you. Are there other things that folks around the table here recall from our last meeting or want to add to the list that Peter has just recited? Okay. If you think of anything, feel free to jump in at any time. So today, if you'll recall, every time we meet, we talk about a different intercept using the sequential intercept model for looking across the systems in our community from before someone may enter into the justice system and including after they have left the system, and all kinds of variations of travel through and around that system. Today's focus is treatment, and specifically the question being asked as our guiding question is, what investments can county council make for the construction and operation of treatment in Monroe County? And before we get into the presentation component, I wanted to talk a little bit about what treatment means, because that's a very big concept. And I feel a little bit sometimes like we can talk at cross purposes if we're not being specific about, for instance, the setting for treatment. That can vary widely, whether we're talking about treatment in our jail, which we do have. Another type of secured facility, theoretically, would be another setting. There are numerous community-based settings, and I wouldn't presume to be able to describe them all, but there are lots of settings in which treatment occurs. There are different therapeutic approaches. There are, of course, different diagnoses, treatment for what. So I think we need to be specific, as specific as we can when we have these conversations, so that we know exactly where ultimately, in answer to the question, county council can make investments, because construction and operation of treatment in Monroe County is not limited to a treatment center next to a new jail on a campus. And I don't want to put that box out there for our discussion. I want to open it up and make sure that we're talking about these different settings, therapeutic approaches, the different issues for which one might seek treatment, different funding streams that go with a lot of these different variables, different points of entry across the system, and making sure that as we look across this, we are keeping in mind the whole continuum and where we might have bigger gaps and need more supports. Do you all have anything to add to that? Questions or comments?
So as always, the conversation today will be difficult. We're going to be covering a lot of topics that relate to mental illness and substance use disorder. There will be some difficult things talked about. So if you or someone you know is struggling with these issues, please seek help. There are a number of individuals here today that can help, and there's also 988. This is an opportunity that we think is important, that we can try to address some of these issues. But please, if you are struggling with some of these, please do reach out. Thank you.
Thanks. Does anyone else around the table or Councilor Crossley, anything to add before we jump in? Okay. I wanted to acknowledge that we do have Mayor Hamilton, Beverly Callender Anderson, Penny Gibbons, Karen Renbeck, and Isabel Piedmont Smith. Just looking to see if maybe they're also here, but they're online, joining us via Zoom. So I'll ask my colleagues to keep me aware. I'm trying to monitor if anyone online raises their hand or wants to participate more directly. That said, let's move to the presentations component. We have 6 people slated to present, and if we have 10 to 15 minutes each, that's an hour and a half, which should be good. I mean, it gives us some wiggle room. So that'll be my guiding principle. But the first person I have on my list is Becca Strite from the Community Corrections Office. Oh, yeah, come on up, both of you, please. Welcome, Mr. Malone and Ms. Strite.
Good afternoon. I'm Becca Strite with Monroe County. Yes, with Monroe County Probation, I am the Community Corrections Executive Director and the Deputy Chief Probation Officer.
DSD, can you adjust the captioning box on this, the display? Can it get any bigger? Really? Well, that's very disappointing. Well, I will remind everybody, if you could do what I'm doing when you talk. I have to remind myself a lot, but feel like you're really uncomfortable up here close with the mic.
My name is Steve Malone. I'm the Problem Solving Court Director for Monroe Circuit Court Probation for Veterans Court, Reentry Court, Drug Court, and Mental Health Court.
So we are here just to give a very abbreviated explanation of how treatment and community justice or court-ordered individuals interact. Again, keeping in mind that probation and community corrections are all one unified department. So if you hear me say probation or community corrections is all the same. Probation officers, when we hear the word treatment, we think of all sorts of treatment that a client might need. It could be substance abuse, mental health treatment, treatment for sex offenders, treatment for domestic batterers, trauma, medicated assisted treatment, and even, we don't consider this treatment, but even the need for halfway houses, transitional housing while people are participating in treatment. The probation department is a certified court alcohol and drug program. So the state of Indiana, through the Indiana Office of Court Services, certifies counties that meet the standards to be a court alcohol and drug program. They certify them for 4 years. It's a rigorous certification where members of Indiana Office of Court Services do come to our office and look through our caseloads, look at all of our documents about why we sent a certain client to a certain type of treatment. They check our paperwork to make sure even all the signatures and dates are on there. They actually also interview clients and probation officers and staff. We were certified just this spring. Again, we've been certified for several years, but just got our renewal this spring. Again, it's good for 4 years. In addition to being a core alcohol and drug certified program, all of our adult probation officers are also considered court substance abuse management specialists, or CSAMs, as I'm going to shorten it to. So again, that's court substance abuse management specialists. Within 2 years of being hired as a probation officer, we are required to complete several trainings, a practicum, and pass an exam in order to be certified as a CSAM's probation officer. Once we receive that certification, we're able to do things like assess individuals for treatment needs, not make a diagnosis, but we are able to assess what someone's needs are. We can make referrals for treatment. We get lots of training in things like confidentiality, ethics, drug identification, case management, all that stuff. And then to maintain that credential, there's a certain number of hours that we have to interact with clients on a regarding substance use, and that just comes naturally with the job. I share all this only because we are a core alcohol and drug certified program. There are certain criteria that we have to meet, or a treatment agency has to meet in order for us to refer a client there. So if a client is on probation, court ordered, and the court puts on the probation client's order, participate in treatment as directed, or follow a case plan, that's our number one clue that the court is expecting some sort of treatment plan. The places that we can refer a client for treatment has to be, there's a vetting process, but they have to be within the network approved by the Division of Mental Health and Addiction, or DHMA. DMHA. So I say that only because we have had agencies reach out to us and say, hey, I've started this treatment program, or they put treatment behind the name of their agency. Unfortunately, it might be a great facility. Unfortunately, we cannot use them unless they've gone through the certification process that allows us to make that referral. There is a vetting process. So once somebody is, even once they've been approved by the Division of Mental Health and Addiction, our core alcohol and drug director will go and actually visit these agencies. He will observe, he will talk to staff. If the agency allows, he will talk to participants. And then he also meets with them to make sure that all of our needs are going to be met as far as the agency being able to provide us with real-time information about a client's participation there, also letting us know the client's successes, as well as if a client leaves or is not participating anymore. The other thing I want to point out about treatment when it comes to court-involved individuals is that it is a lengthy process. So not only are we talking about having to wait for a client to get through the court proceedings, once they're sent to probation, there is a full intake that we do on an individual where we're actually interviewing them up to 2 hours. We're doing a risk assessment, a needs assessment. And then that's where our CSAMS certification comes in, where we're able then to make a decision about what type of treatment somebody might need. And again, we're not talking just substance treatment here. We're talking mental health, sex offender, battery treatment, or a mixture of any kind, co-occurring, anything that you can think of. If a client has received treatment while incarcerated, we are also still required to send to do a full intake and assessment on a client, and still send them for a full evaluation to an agency, whether that be outpatient, inpatient. So we acknowledge treatment within the system, or within the jail or the prison. We absolutely appreciate that and acknowledge it, but we are required to follow up with an outside agency under those DMHA rules. One other thing I want to share is that when we talk about treatment with clients, at least here in Monroe County, we do not consider treatment a punitive sanction. So we are not ordering the courts are not ordering treatment, and we are not ordering treatment solely in response to non-compliance or a violation of probation. If a client is in violation status for something other than committing a new offense, before that client ever gets back to the court, to the judge, our probation officers are expected to do treatment modifications with the client, where they're doing a new risk and needs assessment, where they are speaking with the current treatment agency to get information, to see about progress, see about where the hiccups were, and then work with that treatment agency to make changes to that client's individualized case plan. The reason I bring that up is, again, just to highlight that somebody who is involved in the justice system when it comes to treatment, that is a long process. If their sentence on probation could be 2 years, and that full 2 years they could be involved in treatment, especially if it involves co-occurring or multiple different types of treatment needs, inpatient to outpatient to aftercare, factor in relapse into that, and they might have to begin the process over again. They might also have bounced from treatment to treatment agency just to find the best fit for them. There are, of course, a number of individuals who seek treatment outside of the justice system, and I do want to acknowledge that. But I was asked by our judges and our chief just to bring some context to what we are required to consider when we talk about treatment for the clients who are on our supervision.
Thank you. That was a lot of great information. I would like to see if there's anyone at the table here who has questions. You all probably know more about how they work than I do, so go ahead.
I don't know, does it make more sense for me to ask questions now or wait till you go, Steve?
I wasn't planning on saying much. I'm just going
Okay,
to say
all right.
exactly what she said is what we do in the problem solving courts, but treatment it's in our name, drug treatment court. They have to abide by all treatment recommendations that Becca described before, and our programs are generally 2 years in length. and they may be in treatment the whole time. But again, we pretty much, what she says is what we do. And that we do medically assisted treatment as she described with methadone, Suboxone, or Vivitrol. And we also, if somebody is in violation in one of our programs, we do sanction and incentivize them if they're doing well. And we don't sanction them for necessarily usage. We do what's called a therapeutic adjustment, which is we go back to the treatment provider and discuss with the treatment provider, counselor, case managers there as to what other avenues we have available for them. So just to kind of clear that up a little bit.
Sure. So I think then that brings to the forefront of my mind, what are based on your experience, and both of you have quite a few years of experience in this field, what are the barriers to treatment that individuals are facing here and of course, this body exists to make fiscal recommendations to the county council. What barriers are existing right now?
Cost. So we, unfortunately, the clients have to pay for any treatment services on their own. We are not in a position where we can help with the cost of that. We, of course, try to hook clients up with insurance navigators to work through that process. There are a couple other programs like Recovery Works out in the community, but the cost, just simply resources, where to send clients, not having enough beds, not having enough space, severely lacking in detox options to help clients who need that initial help just to get substances out of their bodies. Transportation, daycare, I mean, you name it. If it's something that's preventing a client from probably also working, going to school, taking care of their kids, the same barriers apply for treatment.
And then a follow-up question is, what's the scope of the service that you're providing here? Are we talking about dozens of people? Are we talking about hundreds of people? And if you don't have the exact number in front of you, a guesstimate would be helpful. Are we talking about 5% of our population, 10% of our population?
I thought I had this bookmarked. We do keep statistics on our core alcohol and drug program. We are talking in the hundreds, and I had this bookmarked. I promise I did. Sorry, I'm trying to find the core alcohol and drug section of our large annual report, but we are talking about in the hundreds, clients in the hundreds, where we are referring clients to treatment.
And that annual report that you're flipping through right now, is that available publicly?
Yes, it is on the probation website through the county government website.
So if a member of the public was curious about a certain statistic out of the community corrections department, they could look that up through.
Yes.
Excellent. So again, the scope is the hundreds per year.
Yes, per year.
That's kind of the range. Okay. No more questions for me.
I did have a question, but it looks like Leah Scott has her hand.
Yeah. My name's Leah Scott. I'm with Recovery Works Martinsville. And I just want to say thank you for your presentation. I know at the treatment level for substance, we have noticed that when our patients are referred to you guys or court ordered, it's kind of cool. And information that we have gathered is the outcomes are the same. So whether a patient comes on free will to treatment or whether they come because they're court ordered, we still get the same outcome. So in the beginning, I know a lot of people might think, oh, they're court ordered, they're just going to do it because they have to. But it's pretty cool to see that the end result is if they're serious about treatment, they make it through the program. So it's kind of cool. I like them whenever they're court ordered. And it's on our side, it's interesting because a lot of times patients will come in and they'll say, well, I have to be here. And I say, yes, you do, but you have the choice. You know, you're choosing to come here, you're court ordered, or you can go to jail. But, you know, preferably I would go to treatment and get help. And we really, from our end, that's how we work it, to say, you know, you have the right to leave at any moment. You're in charge of your future. But again, they want you to get help. So do the treatment option. And then that prevents from landing in jail and just starting the whole cycle over again. So thank you, thank you for everything you guys are doing. But we love the outcomes are still the same. And so it's really cool when you guys refer in. You're right, beds are tough right now. So she's not wrong in that. But yeah, once we get them in treatment, if they're serious about their treatment, it works.
So my question is, I want to go back to barriers because time and time again, we've heard in various meetings that there's a lot of things related to barriers, and the biggest thing is cost. So when you mentioned that, there are clients that are having issues with, the cost, I guess my question would be what percentage of clients are you seeing that are having this barrier with cost? If you know.
I don't have an exact number for you. It really depends. So some of the clients, it really depends on what kind of treatment and how long we're talking. If a client typically, and I am not a recovery works expert, there are probably people around the table better versed at that, but there are some guidelines with that about how much they'll help pay and how long. If a client can get their insurance or recovery works to help with most of it, then it's great. If a client, especially our clients who do have a pattern of getting into treatment, maybe leaving for whatever reason, relapsing, and have to go through the process quite a bit, that can be difficult. I know that the majority of our clients are in some sort of do have some sort of cost concern, not just for treatment, but for anything. And we do work really hard with them to help prioritize for them where their money goes. So while they do have court costs, we know that treatment is the more immediate need, and we will put court costs and probation fees off to the side and say, please put some of your money towards treatment and getting that assistance first.
Go ahead.
Oh, I was just going to say, I know I was kind of mentioning to Steve as well. There was a presentation a couple of weeks ago where, or actually maybe it was the DEI presentation talking about treatment costs. And I was saying, since Medicaid expansion, the vast majority of the people that we see are eligible for Medicaid. Now, they're obviously, Misty, I know last time talked a little bit about the fact that with the end of the extension from COVID, a lot of people were kicked off the rolls and having to work on that. And there's also income. So if you get a full-time job, you get to a certain income, then that will trigger having to pay more. But for the most part, most of the clients we see have no copay. And that's for substance residential, and that's for detox, and that's for, the entirety of their treatment. What is not paid for is childcare, is transportation. It's the costs associated with getting to treatment. So I think that's an important piece as well.
So I guess I have a couple questions. So is pretrial release part of community corrections as well?
Yes.
Okay.
That would be a yes.
Okay. Sorry, we're like, what is the average cost of adult probation? What is it?
I don't know that I can give you an average cost, but I can sit here. There's court costs associated with it, depending on if you're convicted of a felony or a misdemeanor. That makes a difference in what monthly fee you get charged. There are drug test fees if you are on any type of electronic monitoring or alcohol monitoring. There's fees for that equipment. The core alcohol and drug program also charges a fee. If your offense had to do with alcohol or drugs, so like a drunk driving offense, there is a fee for that. So I could not possibly give you an average at this time.
I was just curious too, with problem solving court. I have many friends who are in problem solving court. I have many friends who have completed successfully problem solving court and doing well in life right now. I do have I wouldn't do justice to my friends if I didn't talk about this, because the cost for problem solving court is pretty substantial, correct?
It can be based on the length of time in the program. Yes, they are charged a fee to participate in the 2-year program. And then they're charged during screen fees. We do, or I do, as I just did last week for the council. We get grant money through CARES, and we also do grant money through Indiana Office of Court Services. We ask for money to reduce that cost. Our lab screens that we send off to the lab are a little pricey, but I can offset some of that by getting these grants and doing only charging the offender or participant, let 3/4 of what they would pay for a regular screen. We also do, speaking of transportation, I also write a grant to get money for bus passes for monthly bus passes as well, that we hand out to those participants in our program that are in need of those bus passes.
Also, so the cost of those associated drug tests, ones you send off, I believe, are $25 for send off. So, and problem solving court, people sometimes are screened 4 to 5 times a week. That's pretty high cost.
So, not to get to prolong this, but
Yeah.
there's a method to the madness as far as how, when somebody comes in, when they're initially in the program, they're in phase 1, they're coming into day reporting every single day of the week. And they have 100% chance of being called in for a urine screen every single day. However, we have it built into our system that there's only a percentage amount of time that they get screened. So those that are early in the program get screened a lot more than those that are in the latter phases of the program. So after about 6 to 9 months, those types of tests diminish. I don't know how much, but it's done on a random basis and evidence-based practices, and all the data and the studies that have been done on problem-solving courts show that if they have the ability, if they know that they have the ability to be tested every single day, the results are much better. So we try to keep it to a minimum as much as we possibly can. So when I was talking about the grants, so those screens that you're talking about, I write a grant for what we call instant cups, where we get the result instantly. We don't send it off unless it's positive for a specific substance. We don't charge them extra for that, and those are $10. So we try to offset it as much as we possibly can. I'm not gonna lie, yes, it can be expensive based on the amount of time in your program. But a point I've made on several occasions is, if you're not out using, you're going to save money because you're not spending that money on your substance. Now, enough to offset what you're charged, I have no idea. But
it's just really difficult because sometimes, I think that we are living in Bloomington, so the cost of living for your clients is astronomical already. And the quality of jobs that are offered to people like me and folks who are in problem solving court is pretty low. So it is difficult to get your footing there. And one last question, so once they complete their 2-year program with you without sanctions or violations or extensions, are they eligible to get off of problem solving court if they don't complete their financial means of it, like probation? I personally was released from probation without paying before, but I didn't know if problem solving court would do that as well.
I will go back years ago when problem solving court started in 1999, and one of the requirements was to have every single one of your fees paid off in full. I will tell you that's not the case anymore, based on their financial situation, what they went through, what they have available, what we think they may or may not be able to do based on disability, other stuff. We have waived those and put them on the judgment docket, but still allowed them to successfully complete the program and have their charges dismissed.
That's awesome. Thank you so much for your time.
Any other questions from around the table or online for our community corrections and problem solving court folks?
I think one other comment, Steve, is just to talk a little bit about the team impact of the problem solving courts, because I think in terms of community coordination and collaboration, it's a really good example of how to ensure that people get all of their needs met.
Yeah, we as a problem solving court team meet every single week on Mondays. And we have representatives from the Defense Counsel, Public Defender's Office, the prosecuting attorney, Centerstone, Amethyst House, IU Behavioral Health. We have our field officers, our case managers. We have for vet court, we actually have somebody from the VJO. He's a VJO from the Veterans Administration that also sit on our team every week, and we make decisions based on how they are doing or not doing well while they're in the program. And then we meet every single week in court for status hearings to discuss their progress or lack thereof as they go through the programs. Okay. And these are volunteers, except for those, myself and my case managers and field officers. Everybody else on the team is a volunteer. They don't get paid anything extra to be a part of this.
And I think one of the points that's really important here is that you get to hear different voices that have different perspectives about things. So, I mean, you're asking about fees, or you're asking about, maybe somebody had a relapse. What do people think? I mean, you have the probation officer's voice and the judge's voice, but you also get to hear from the treatment professional where they, kind of came to you and said, hey, this is what's going on. And I think just from a model standpoint, again, having those voices at the table is something that's really powerful and important. So I think it's worth mentioning.
And I don't want to overshadow anything that Becca had to say regarding probation, but these problem-solving courts are some of the most intensely scrutinized, studied data analysis, cost-benefit analysis out there. We did a cost-benefit analysis years ago, and we were showing that we were saving the county almost $5,000 per offender that's in the program. And as Linda was mentioning, some of the costs do add up, but that is sometimes based on the fact that they may be out to coming to court once a month, or not coming to day reporting, but once or twice a week, and they relapse, and then we move them back, re-engage them with treatment, and then as a result, they may be getting more screens as a result of that. So hopefully that makes a little more sense as well.
We have a question online asking what the process is for getting problem-solving court fees waived. So you mentioned that it's kind of based on a lot of different things, but what would the process be for someone?
It's basically the case manager sitting down with the participant in the program, looking at what they're bringing in, what they're having to pay out, and what they have left to pay. We want them to fees at first, when they first start our programs, we want them, as Becca was mentioning about treatment, we want them to pay their treatment cost first and foremost, because that's what's important to us, is make sure they're getting the treatment and getting the appropriate treatment. Then we'll start working on their fees. There's no set process as far as the fees are concerned. We would like for them to pay everything off, even some of their past fees. So they start from scratch when they start the program. So they're starting from scratch. That's not a requirement anymore. We don't ask them to do that anymore, because it can be very costly. So we'll do a cost benefit analysis to see where they are in the program and what they have left to pay, what they can afford to pay.
There's a follow-up question from this is from Jordan McIntyre. Is the cost benefit analysis advantageous to the county government or to the individuals in the program?
The county. Plus, they're not spending that much time in jail any longer, as well as a direct result. So not costing as much and not coming back through court for court proceedings as well.
But the data going into the decision then, though, is based on the individual in the program. Right. It's just that it is a cost saving measure for the county, and we want to be upfront about that. This is a good question. I want to lift up. Is problem solving court at capacity? And so are people, there isn't any like, we're full, you can't participate because we don't have the capacity.
Absolutely not.
Okay.
With COVID, we took I don't want to say a hit, but there's a lot fewer participants in the program because of COVID, and then some. It's a volunteer program. We can't force you to come in to a problem solving court. We get the referral from the prosecutor's office. They think that somebody should be considered for the program. They sit down, as Becca was talking about, we do an intake, we do what treatment provider, we send them for a treatment evaluation, then we determine whether or not they should actually come into the program. And then we go from there.
Great, thank you. Any other questions from members around the table or online?
I finally found my page. In 2022, just clients who went through our court alcohol and drug program, so they were in the official program with a referral to treatment, we served 535 individual clients.
What page is that on?
It's page 87 in the PDF.
Great. Thank you. Thank you very much. It's a lot of information, but really important, and I appreciate your time being here. The next group on our list is Sheriff Marte and team is what it says. Welcome to all of you. And did you have a talky talk kind of presentation or a watchy kind of thing?
Kind of both.
Watchy
Kind of
talk.
both.
Okay.
Is it up there? Oh, here we go. So it's going to be hard to top off what we just heard. That was great information, by the way. It really was. Can everyone hear me? Am I loud enough? Okay. When we learned that we were going to present on the topic of treatment, we didn't really want to reinvent the wheel. So what we did was we pretty much sat down as a team and recall some of the conversations, different forums that we participated in, and I'm sure it was quite a few, and heard from council, commissioners, and most importantly, the public as well. And we listed 4 positions, should be coming up here shortly, that we felt was a common ground for trying to help people in need when they come to our facility. And with the understanding that funding is really scarce for everyone to receive, and it makes sense. So we were trying to think of a bare minimum as far as the positions that we're going to show you here shortly. You go ahead and go to the next slide for me. We thought of additional qualified mental health professionals. And the reason why we're trying to find people and help people where they're at. And the numbers for us is just growing dramatically. By the time they get to our facility, I mean, that you're hitting rock bottom. The other thing that we came to the conclusion that people brought up before in the past was the substance abuse a counselor. We've seen the success when we actually find people assistance right away. And then the other one, which was, we found it was very important, was the reentry case management. That is something that once they're with us, people do well. But unfortunately, sometimes when we don't have assistance, when they leave the facility, they find themselves right back again. And then the last one that we thought of, in consensus with the council, commissioners, and the public, was a jail program director to make sure that that individual solely job is to make sure that that person is receiving what that person truly needs at that given time. A fix won't work for everyone, so we have to be conscious of that and meet that individual where they're at. So, because right now I can tell you that, you know, not only are we understaffed, we're not being proactive where we know we can be. We've been here now for over 7 months, 8 months, and I can tell you that is an eye wakener for us, because we do know, as we talk to people, as we make their environment in the jail different and try to make it more humane and there to actually serve and help people, not to come back again. But I could tell you that at the right rate that we're going is very difficult, because these are the bare minimum that we need to try to make a dent, so people won't come back. So I'm going to turn over the actual presentation now to the chief deputy, and then to the jail commander, but they could tell you hands-on as well what they have observed in a short period of time that we've been here. What we want to do as well is bring a full circle, and in respect of time, we'll probably just give you just one example, but that's just one of many that we face on a daily basis.
So what Kyle and I are going to do here, we kind of broke this down into, let me back up here. I think a lot of times when we all meet, we kind of get lost in, it always goes back when we're here about the new jail, about the new jail. And this, on the agenda, it's treatment and construction. So we understand that this is, what we're going to talk to you about is some things that we want to incorporate into that new facility. But I also want you to keep in mind, as Kyle's talking here, is that many of these things, if we have the resources, we can incorporate right now. And I cannot stress, we've talked about this over and over again, and I'm going to bring this home when Kyle gets done, that, we're probably 3 years out at best, for this new facility. I mean, that's running a fast pace. We can't afford to sit here and go, okay, hey, when we get that new facility, we're going to do all these great things. We got to start right now, because there are lives that are hanging in the balance of those 3 years that may be won or lost in that period of time. So that we don't have the luxury of waiting until it's nice and convenient. We have the room and we have the space and we have all of these different things. We've got to adapt to where we are right now with who our clientele is right now, and start making some movement. And I hope we come to a point where we start moving instead of talking. There's just an awful lot of that, and it's a lot of good discussion, but discussion means nothing. And once you finally realize, okay, here's the issues in front of us, what are we going to do? Our whole careers are based on action. We can't afford to be inactive when we engage in our profession. So we probably push a little harder than most. But so keep in mind, please, as Kyle's going through, don't confine it to a new jail. Confine it to this moment and at this time, and then we'll kind of talk about how it all comes together here at the end.
When we talk about treatment and construction, we kind of incorporated things that we've all talked about, things that we've learned on our visits to other facilities, things we learned through the pony training, and specifically what we're really looking at is how do we deal with treatment in a facility. We've already constructed different ways in our current facility in which we're trying to mitigate that process. We've made a lot of positive strides in doing that, and we can talk about that at the end of this if you'd like. But in terms of treatment and what we're looking at in the construction build, we are trying to incorporate specifically a transitional type facility. As we've all spoke about, we like to get people in and out, but we like to get them focused on bettering themselves and at least giving them the opportunity. So when we talk about a transitional mental health dormitory, this would be pre-evaluation upon initial intake. This would be an opportunity for our mental health professionals to really understand who they're talking to, what programs they're already a part of, and how to direct them through their time in our facility. I think what a lot of jails in the United States specifically have an issue with is you got a person that comes in, you get them evaluated, and then they're in general population, and we go through that process throughout. And you offer programs and you offer care, but sometimes if you don't take care of that person, as soon as they come in, they may not be open to those programs. They may not understand that path and how to better themselves. So I think with the transitional mental health dormitory, what we're trying to do is post intake, really get them an opportunity to look at things through a clear view. Specifically, a person that may be intoxicated or may be impaired on other substances. This gives them an opportunity to find themselves before we move them to the darkest places of the facility in terms of what the public looks at it as. We would like something in the new facility in the construction located near intake, somewhere where they're not continuously having to go through that crisis and really have to relive that moment again and again and again throughout their time, so they can have an actual opportunity to really look at and speak to and open themselves up to the people trying to help them. What we're looking at in terms of that is simple as soundproofing for their sake and others. It gives them an opportunity to really kind of ground themselves, because you get lost in the noises or the lack thereof in a jail facility. Sometimes silence in of itself is deafening. We would like it to be located near a mental health dormitory, because it's transitional. If they can get that help, we can get them into the actual mental health dormitory. They can start going through programs and group sessions, and the folks that we bring in for other programs can be involved in there. We'd like to look at the possibility of adjustable lighting and natural lighting and sound and ambient music or things like that that we've all talked about. You want to touch on that at all? The mental health dormitory in of itself is a more, I don't want to say permanent placement for a person, because as you guys that know the jail and no programs and no treatment, you can go up and you can go down, but it's never just stay. It's something we want to be open to and bettering themselves. It's the same as the transitional mental health dormitory, but again, this will have specific programs involved through our social workers and through the other positions that we talked about.
You know, something as simple as adjustable lighting. You know, we were taking a tour and just talking to the inmates as we do on a regular basis. And one of the residents said, you know, the flicking sometimes of light or too much light causes me to have my epilepsy attack type of deal. So that's important for people like him. So we moved him somewhere where we could adjust the light so that individual could rest. Because if someone is tired, angry, confused, not on the medication properly, something as simple as sleep means a lot. So that's the reason why we put that up there. The next one you're going to see where it says sound and music. The first time I heard that, we were talking to one of the caseworkers, and the light bulb went off. I never thought of that, because some people, particularly the artistic, music kind of calms people down. So we want to be able to provide that, because every individual is very different. So these are the things that we're talking about, thinking outside the box, that we, as the chief mentioned, could try to incorporate right now. Because I tell you, just imagine if you have a family member or loved one that for whatever reason, God forbid, ends up in that establishment. I like for us to have all the tools that we could do right now. And I see people, you know, suffer because we're not doing it. And these are actions that we could do right now. So when the chief mentions, bear with us, that we're of the culture in our line of work that when people need assistance, it's just hard for us to just slow down. You know, we're used to, okay, we could help you and we got the tools, let's get it done, let's do it. So I do appreciate your understanding a little bit why we push a little bit more, because we're looking at people's lives right now.
Specifically about these things, you'll see adjacency is something we really focused on, and we look at a new facility. That's things we've already started to do in our current facility as it stands. Obviously, it's on 3 different floors, so that's hard sometimes. But when I talk about adjacency specifically, what I'm really talking about is a person that comes in that has a substance abuse issue, not violent, no other outlying charges. Sometimes exposing that person to the rest of the facility is extremely harmful to that individual. So if we can move them in the confines of that area, in the confines of programming and assistance and group counseling spaces, and not expose them to the jail aspect of being incarcerated, we believe, and as well as you guys that we've all talked about, that it would be extremely beneficial to the people who are housed. We talk about additional mental health space. We're talking about offices, record space, individual counseling space, group counseling space. Again, these are all things that we've all spoke about, but these are things that we believe, especially through the pony training, that are extremely important to that process. What we're really looking at in terms of what the research that we've done on our side is a medical type dormitory, but that incorporates more than some people may think about. Again, reverse negative airflow. A lot of facilities have it. We only have one cell. And if you're not sure what that is, it's really just an air system isolated to one area, to one cell that doesn't recycle the air throughout the entire facility. When you think of sickness and things of that nature, those are things that we really have to keep an eye on. But one thing that we are, I don't want to say adamant about, but we believe is very important, is we've had 3 inmates now who were pregnant when they came in, one of which gave birth while incarcerated in our facility. She was released to give birth and brought back through the courts. But what we really thought about was what she would go through when she returned, being without a child and just giving birth and being thrown right back into general population. So we tried to find a place for her that would be a transitional type cell. But we believe it would be important in a new facility to have a post-pregnancy quiet space or a lactation space if that's what she wants. We offered her that opportunity. She did not want it, and that's her prerogative, but we believe that it was important at least to give her that. Special needs cell, when Penny specifically talked about the silver rating, Penny Githens, these are things that are required when you talk about medical dormitories, is a cell, at least one, that accommodates a hospital bed. And when I say accommodates, it means fit through the door. Our doors are a lot smaller than a hospital room door, obviously. And to get that silver rating, to get to that level, you got to have things such as special needs showers, restroom facilities, higher toilets, handrails, wide entry showers. Those are all things that handicap accessible people need. And we have very few of those cells in our facility now.
We have people incarcerated in our facility that are confined to wheelchairs. It's not that uncommon. So right now it's quite pitiful, quite frankly, to have folks in that position there, and we're struggling to give them the basic needs they have just to be able to go through daily life in a humane manner.
I think sometimes things get overlooked. For instance, we talked about somebody in a wheelchair. We have 2 people in walkers. So these are the type of things that can't go into general population. You can't put that with other inmates because of the steel and the metal and the things that are in those devices. So you have to find additional housing for these people. For instance, there is one person, without getting too into it, because I mean, we don't want to give people's because of HIPAA, but he has a catheter. And these are things that need to be changed multiple times a day. Medical changes it, but the jail staff themselves have to handle it. And we're not specifically trained for those type of things. These are just things that are thrown onto the facility that we have to deal with on a daily basis that sometimes get lost in the amount of work that the correctional officers actually do. When we talk about additional medical space, just as a mental health, we're really looking for records, staff office space, a dental examination room. Right now, we just run it out of basically a closet inside of the jail. I think that the dentist was here she was actually here today, and I think she saw 31 inmates. Some of these are tooth extractions. Some of these are just general evaluation for possible surgery, things of that nature. But really more specifically, the need for additional padded cell space, observation space. We have one currently in our facility. And the need for that padded cell goes beyond what you may think may be common sense, because, for instance, if a person exhibits self-injurious behavior, we are mandated by the state of Indiana to do certain things, to put these people on surveillance, to check on them intermittently at different staggered times. But more specifically, these are people that are actively trying to harm themselves. So outside of contacting the hospital and contacting the courts and getting these people direct evaluation and emergency detention orders and stuff like that, sometimes people don't rise to that occasion. So if they're hitting their head off their cell, we need to move them to a space where it's softer. It's more sanitary, it's clean, it's closer to everything, it's closer to the medical offices. And only having one in a 200 to 225 person facility is extremely difficult to manage. But we've made do with some of that.
Touch a little bit on, just in general terms, on the individual that we received that had the broken back, how we had to struggle with that.
Well, the individual with a broken back required rehabilitation because of the amount of equipment that was required for him to get up and move and go to the shower. We physically had to help him around. We had to help him with his walker, push him in his wheelchair. We had to dedicate officers. The assistant jail commander walked around the facility with him to try to rehabilitate him through his process. Luckily, the courts got him. I think he was only there for 2 months. But luckily we got some movement out of that, because we had to take up one isolation cell his entire stay. When he first got there, again, touching on that hospital bed space, he was somebody that would have really benefited from that, because we can give him 2 or 3 mattresses like we did, but that's still, I don't know if anybody's ever felt those mattresses. That's still not enough for somebody with, serious bodily injury and really recovering from that.
But we had to consider also definitely keeping a close eye on that individual, because if you think about it, you're alone, you by yourself, you can't be in general population because you have a broken back. But the psychological damage that does, because you're not talking to someone, that human interaction, we really had to be concerned with that individual. But here again, it's one of those things that we want to move as fast as we can, but without the resources, those are the things that we have to deal with on a daily basis.
This next part, you look at the trend of jails in the U.S. and you see a lot of jails going to this veterans dormitory space. As of this moment, we have 5 former veterans, at least ones that acknowledge that they are. Some guys don't want to talk about it. But the importance of these dorms has been proven statistically again and again, because when you get guys or girls who have gone through the things that they've gone through their service in the military, sometimes, and substance abuse counselors that can attest to this, sometimes the best people that they can talk to are people that are going through it too. We can talk about all the programs that we want to talk about and all the things we want to do as a sheriff's office, but if we can't meet people at that level, sometimes we are not going to be adequate in of ourselves. So a dorm like this with veteran specific programs and really peer work, veterans helping veterans, that has shown to be extremely beneficial in facilities. I just went to a jail conference in Omaha and visited that jail, and they had an entire veterans dormitory, and they had it was actually kind of nice because they had their beds set up where it was Marines, Army, Navy, and they had contests to see who kept the cleaner side of their jail. And it was actually awesome to see everybody working together, because sometimes really veterans get lost in the shuffle. A lot of what we hear is the same things that we hear about us. I mean, we elected to do the job, so we deal with the consequences, whether it's emotional or physical. And sometimes veterans get overlooked in that aspect as well. We talked about more jail program space. That's something that we've hit on throughout the beginning. It's something that all of us have hit on. We're very limited right now. We have 11 total programs, and we're also working and speaking to the IRAC program and potentially incorporating them in our facility as well. So you can see all of the programs that we have available now. It's in one space. It is not something that we can do for years and years and years without really looking at a different build in a new facility.
We as a team discussed this multiple times. At what point, and this is going to be very difficult for us, but at what point do we have to turn away a program knowing that it could be helpful because we don't have the space? And I assure you right now, the staff are doing the very best that they can with the very little that they have right now. And we're still losing correction officers to other paying better agencies. And, we cleaned the place and we sanitized it and we made it brighter and tried to give them things that we have control of. But we cannot do the job that we want to do. And we know we could do a better job at the rate that we're losing people right now. And that's very difficult for us to tell someone you can't better yourself because we can't pay you more. That's very difficult. So we're doing the very best that we can with what we have right now. I don't want those numbers to reduce. But without the staff, there's very little that we can do at the rate that we're at right now.
I think sometimes what gets lost when we talk about space is time. With 11 programs, and that's outside of the religious services that we offer in one room, which can fit 15 to 20 people max, I would say. I think sometimes what gets lost is that we have breakfast, lunch, and dinner. Those serving times take probably 2 hours each. There is no movement typically in the facility during that time. Courts run during a certain time. Different programs like GED and ServSafe and things like that, they have a specific time in which they come in. But that means, for the most part, 9 programs are fighting for the same time slot. So typically, what you're going to see, especially from volunteer programs, that person works a job and then comes in and volunteers their time at night, is we've got a time slot from 6 p.m. after dinner trays to about 9 or 10, depending on how we want to do it. That's 4 hours. So we've got to fit throughout the week 11 programs into those 4 hours a night. That's without following the Indiana jail standards and allowing for religion and allowing to do their research for their case load and stuff like that. So really, going to the next slide, we've got our chaplain, and then we've got 6 other church programs, religious programs, because we have to meet, depending on the inmate, they have specific religions. So there are religions that we have that aren't listed here because they're not all the time. There's just some people that come in and have one, and we have to look into the community to see if we can find somebody, or we have to make a computer available to where they can research their things. So when we talk about program space, we're not just talking about multiple spaces, we're talking about time. And with the multiple programs and all the time it takes to manage those spaces, that means more officers. So we speak a lot about what we can do to better the time that the inmate spends in the facility and build a proper foundation for them to build from when they get out of the jail. But a lot of that is time management inside the facility, because if I walk through the jail every day and I talk to inmates every single day, I'll go down and sit down in their block with them because I think it's important for them to see me and talk to me. And one of the things they'll say is, hey, I've been asking for this, or I've been asking for this. Well, I go back to the officer. I'm like, hey, did they ask for this? And they're like, yeah, I'm trying to get to it. I've got to do this, this, and this. And I'm like, I'll do it. And that's what it takes. It takes people willing to do more just to provide adequate service to some of these people. So we can talk about all these things, but unless, like Chief Deputy said, unless we're willing to truly act, we're really looking at being behind the 8 ball, and that's not something that we do in this administration.
And the jail commander is being very, very polite and very kind here. But when he steps in, it takes away from his role of making sure that that facility operates where it's supposed to, humanely and safely. I could tell you that incidents, I could tell you when he's not there, because I have to be more alert, because things do happen in that environment and quickly. So what we're saying is, very frankly, we need help with the people. We need more staff. I appreciate what they're doing, jumping in, and we signed up for this, and we know the challenges that we have. But it comes to a point that we cannot provide everything we want to provide and sacrifice the safety of all staff and the residents there. Because the last thing I want is someone to truly get hurt because we didn't do it the way we know it needs to be done the right way.
I promise we're almost done. Other space consideration is we've got a library now. It's literally just a closet that the Monroe County Library comes in and they conduct that service for us through a contract we have with them. But also a stylist, someone who can do haircuts, and a space specifically for that. Right now she comes in and we say, well, we got indoor rec available. Well, we got the multi-purpose room available. Well, you're gonna have to try to do it in the hallway today. So it's something that we're required to provide inmates that we have to make work on the fly depending on what we have available.
Okay, we talked about a lot of things here, maybe straying from the topic of treatment just a little bit, but it all kind of comes back. So I'm going to try to bring this home to really what this whole conversation is about. But Councilor Willis, you made a statement that rang true right at the very onset of this. You talked about investments, and that is kind of the basis of all this. You know, what are we going to invest in? Because if we don't invest, it's just not going to happen. It simply isn't going to happen. So I'm going to tell you a little story here in just a second here. But while we do this, I'm going to come back to this investment topic in just a second. But when we have the folks in jail here, they're probably, after they've been there for a while, you know, boredom sets in. You know, there's all kinds of things that happen to someone when they're incarcerated. And in the place they're in right now, it's unpleasant. So they become probably more open to treatment while they're there than maybe any time in their lives, because what else are they going to do? And if we offer it, they soak it up like a sponge if we're able to offer it. So we're missing a golden opportunity during that period of time. And one of the things that's in our statement is we want to send people out of that facility better off than they were when they came in. And I'm not sure we're doing that right now. And there's a term, and we've probably all heard it, and it's a term that I've grown to detest. Particularly, you know, I spent a lot of time on the state police, but since I came to sheriff's offices, it's called the frequent flyer. We've all heard that. And what that really means to me is, for us, it means frequent failure. Because if we've got a frequent flyer and we're pushing them out, we're bringing them in, and we're putting them in a penal facility, and it's all punitive, there's no skills. We're not teaching them skills. We're not trying to treat the root cause of the problem. We push them back out with no resources. What are the options? It's to go right back to where they were. They recycle back in. So when I hear frequent flyer, I don't assign that so much to the person. I assign that to us, because we're almost condemning that person to be in the frequent flyer. And I truly believe that. So, I want to tell you this story here, and then I'm going to talk about investments in a different perspective on some of this. So we had an officer, you may have heard about this. some time back, but he was out in the alleyway taking a short break, talking to one of our bail bondsmen. It's a nice day, and he hears a commotion going on, and this person comes up, one of our frequent flyers comes up the alleyway there, and they actually greet each other. He says, "Hey, how you doing?" "Doing fine." Well, as he turns his attention back to the person he's talking to, and this person goes by him, he has a metal thermos bottle in his hand and hit him in the back of the head with it and split his head open. This person has substance abuse issues. This person has, he's got some mental illness issues, but he has been a person that has rotated in and out, in and out, in and out of our facility over and over and over again. So I'm going to go back to the investment part. And I think we're looking at this completely wrong. We look at the cost of treatment. What's that going to cost? And we'll hear this, anybody that's going to present to you is going to talk about the cost of doing this and cost of doing that. What about the cost of not doing it? I think that's where we're at here. We need to look at the cost of not doing what we know we should do. So we've got to reach down, we've got to find it. There's a lot of smart people in this room. There's a lot of smart people in this community that are vested in this community, probably more so than any place I've been. So I'm going to show you this picture here, and I'll close with this. Go ahead, show the picture. This is our officer. The back of his head there with 7 staples in his head. And I posed the question to you, what is the cost of not treating? Right there it is. That's the cost of not treating. That could have been anybody. It happened to be one of our officers, but that's the cost. This person that did this because because we have failed while we had him in our charge to turn this person's life around. And don't get me wrong, I'm not one of those persons that he bears some responsibility here. I'm not saying that. I'm just saying that if we have the resources, we have the ability, we have at least the obligation to try to turn that person into not being a frequent flyer, and thus the cost of not treating is going to be more than the actual cost of doing so. Does that make sense to everybody?
So that concludes our portion. We wanted to bring it full circle. That's just one example, as I mentioned, and being respectful of time, we decided to show you the most recent one. But our fear is that could have been a whole lot worse. But we deal with this every single day. We have gotten together and talked, the studies, surveys, gather data. I think we're ready to take action. I really do. Because when I was informed about that individual, that officer that was doing the right thing at the right time, and we know this individual by name, and we know that he's been with us before, and we couldn't do what we really needed to do. And that's the outcome. If you have any questions of us, we'll be more than happy to try to respond.
Thank you. And thank you for not just taking the time today, but obviously putting a lot of thought and planning into what you were sharing. Appreciate it. I'll turn it to my council colleagues first. Do you have any questions or comments?
Just in the respective time, because I know we have other presentations. That was a lot, but it was very informative. So I appreciate y'all giving us all the things that you continue to give us, and just also want to give you all credit where credit is due, how you have been trying to come in and change the culture of what the facility has been like since you stepped in since January 1st. So I know it's a work in progress. So I appreciate all the things that you continue to do. I know we received your 7-point program or plan, the council did earlier. And I want to go back to the jail program director, because a lot of the questions I had were X'd out because some of those were answered. So with the 11 programs that you have, I guess who right now is handling all of those programs?
I can figure this out. All of us.
Okay.
So
that one-
if something new comes in, for instance, there have been multiple programs that the sheriff was directly approaching the community. He said, "Hey, I spoke to so-and-so, here's their contact information. Can you reach out and see if we can fit them in?" There's been a couple times where I've had to say, "Hey, we've got this program 3 other times already. We've got something that works in the community already. We may have to shelve it for right now because of that space." But our liaison does a lot of that handling now, but he also does mail. He also helps out on the floor. He does everything. So if we could find somebody specifically, because also involving with these programs, as you have to vet the people coming into your facility, you have to look into who they are and what possible safety risks they could present. This takes time. I mean, if we had some instances now where I've been like, "Hey, I actually know this person. They've been in this facility before. They were extremely violent last time they were here. We may want to give this some time and let's talk again."
Okay.
Part of the problem with not having someone that facilitates this full time is you lose continuity.
Mm.
And when you lose continuity, you get someone halfway through a program, things get busy, then you drop it off for 3 weeks. You pick it back up. People have lost interest, or they've lost where they're at. They've lost sight of the goal. They've lost sight of the discipline. So it will bring continuity and stability to those very, very important things that you're always looking at the biggest fire. What's the biggest fire? Well, programs may not be the biggest fire for the day, quite frankly. And it always gets pushed to the back. It was what I'm trying to say to you.
Okay. Do you have job descriptions written for these positions?
We have some, yes, but we're kind of gauging a response before we, went all, at it directly to see what y'all's guidance was for
Okay.
us.
All right, thanks. Do you have a question?
I was gonna say, or no, you're totally fine. You're fine. My other question is, I saw a lot of Christian religions that come in, and I know you have mentioned before, that there are all different faiths. Is there any other religious faiths that come in that are non-Christian, like Muslim or anybody else?
So that is predicated on what the people inside the facility ask for. Like Muslim specifically, they asked for some prayer rugs. They asked for specific things that we give them so that they conduct their religion themselves. But if they don't ask for somebody to come in and speak to them, they may ask for, like for instance, there are some programs that are available on cable that we provide that people watch every Sunday. It just depends on what they ask specifically for, and we bring that in.
Okay. I guess my final comment would be the fact that the cost of not doing it, what you just proposed to us, I think that's a really interesting point, because I think we see that now. We don't have to see it inside the jail. We see that spreading all out. Go down to Seminary Square, you see that there. You see folks right around Walnut Street, we see it there. I live on the south side, I see it there. We're seeing it in every aspect of what we as society has done, like have not done, and what we have done to fail some of our community members. It's a shame. It's very personal for me. It's very personal. Lots of folks don't realize. My father passed away 2 years ago on Friday. And my dad was a veteran, so I appreciate all the things that people are doing. My dad was a disabled vet, Purple Heart, Vietnam War, came back in a country where people obviously didn't appreciate that war being happening. And his coping mechanism was alcohol. And for years and years and years, that was his coping mechanism. After treatment, you go back, do the same thing. Treatment, go back, do the same thing. And this didn't happen here. I'm not from here, I'm from Gary. So he had opportunities for him to get better. And unfortunately, after years and years and years of alcoholism, it took a toll on his body and he passed away. So I get the whole point of what is the cost of not doing it, because we're doing it now. And I'm really sick and tired of us. And we should all look at ourselves and just go, what the hell are we not doing? And why are we not doing it right now? And it's very easy for us to put the blame on everybody else. But in a town and in a community that we so very much say all the damn time that we are so progressive in our values and what we believe very strong and very firm in, it really pisses me off, and excuse my language today. It really makes me frustrated that this is where we are right now and why we cannot do better. And as you mentioned, all the stories, all the surveys, all the things that we continue to do, all the things that we continue to pay for, all of those things, we can do all of that, but there are still people on College Avenue that still need help. There are still people that go to Centerstone, New Leaf, Courage to Change, all the other places. Hell, maybe they don't even go to these places because they don't know where to start. And if we start giving a damn about what it is that we need to do in our community right now, I could only imagine what we can do, where we can stop looking at the cost of not doing it and look at the benefits of us investing in our community. So I challenge ourselves and anybody watching, anybody responsible, to continue to hold us accountable. But yes, I am there where you are, and I am frustrated, and it is disgusting to see where we are. And I'm tired of us saying what we can do, what my hands are tied. All of us in this room have a very big responsibility, from the small to the top, and we need to do something. We have to do something now, because I don't want to keep looking at this. I don't want to see that picture of that correctional officer. I don't want to see anybody harmed by anything. But we have to start doing something and doing something now. So, sorry.
Let me respond to that in two things in 30 seconds. First, I appreciate your father's service and your admiration of it. I have the same thing with my father. But if you'll read that 7-point plan, what you'll see in the very first paragraph is the sheriff makes the statement, as we've spent 6 months here, 7 months. He's concentrated, what are the things that we can do right now? And every one of those 7 things are things we can do right now, that we are, the only thing holding us back is ourselves and what we're willing to invest. So that's the whole premise of that document. If you read it in its entirety, that's the whole premise of it. What can we do right now? The jail's coming, but what can we do right now?
No apology necessary. No apology necessary. I think it's very well said, actually. Would you like to ask a question?
I have 2 very quick questions. I'm really interested in hearing our other presenters, and but first of all, I'm feeling the feels, but then I'm going to go right back into my head, and I'm going to ask some quantitative questions. The first is, you mentioned dormitory sizes for mental health or transition mental health. What does that look like in terms of bed size? Are these like 10 beds, 20 beds, 5 beds? How big are these things?
Well, I think that it's really predicated on conversation. So if we're looking at, for instance, we've got 200 inmates in our facility right now. Well, I think is it 210? Okay, we're down to 198 after our releases. So right now we have 20 people in a mental health dormitory right now. Each of these people require a single cell. They can't be housed with other people. some of which don't want to be housed with other people. However, we have a lack of surveillance in that area. It's something we've spoke about before. So if we talk about in a new facility, I think there's a difference between us creating a mental health dormitory and us having a mental health dormitory that's in transition or in, basic program operation. So I really think it's something we as a team through the Pony program, we talked about the different, the amount of inmates, the different security levels, and all the things that have that impact. I think if I sat here now and gave you a number, it would not do a new facility justice.
Sure, that makes sense.
And Counselor, I think that's where you're gonna see that, we all talked about the transition team. I know that's a big subject of conversation, but that's where the transition team is really gonna do some heavy lifting. We're gonna analyze, and that's gonna be a data-based, hopefully, decision that transition team is gonna provide.
I understand, and
And to be fair to you, Councilman, that for the 3-day training that we had, that was the last topic I think we talked about, determining the size. Unfortunately, you had to leave. I think you had something going on, but that was the very last thing of the actual size of how do we come to that conclusion. And that's one of the responsibility of the transitional team. And that's one of the things that we're finding a little bit difficult right now is because, if we do not have an adequate transitional team to actually think of these things that we're going to, like you just mentioned, down the road, we could make serious mistakes that we might not pay for it now, but when we're ready for the new jail, if that comes, when it comes, we might have to pay for it then. So it's very crucial that we take this portion, because of the 3 days that we were there, that brought it all home for me, particularly that don't make the mistakes that you made already in the past, because that team is the one that's going to make sure that this doesn't happen again.
Yeah, I can elaborate a little bit. When this jail was built, what number do you think they had for mental health capacity?
0.
It was 0. So just in this time, we've changed this much. How much are we going to change in 30 more years? So I think it's unfair to sit and try to give you, and I know where you're going with it, and that's where we should be at. We should be talking about this. But it's hard to just give a number right now. I mean, we would have to talk to all the different people at this table to even begin to think about what we're going to do for housing.
All right, well, maybe we'll come to an answer next week or next time we meet.
Tomorrow.
Just one more quick question here. You partially answered this. There's a perception out there. This is the reason I'm asking this question. There's a perception out there that if we did not build a new jail, we could open the doors and allow people to leave the jail into treatment. And so I want to address that perception with a series of questions here. The percentage of people on a given day in our jail with a mental health diagnosis is around 10%, 15%.
Severely mentally ill, that runs anywhere, on fluctuation between 17 to 22% of severely mentally ill diagnosis based on our medical professionals assessments.
So you've got 10% in the mental health dorm, and then you have another, X number of people out in the other cells or dorms, excuse me. Okay. And okay.
I can elaborate on that just a little bit. So of those severely mental ill inmates we have in a facility, they're not just in a mental health dorm. Some people require 24-hour surveillance. So we have to isolate those people so that they can get medical evaluation, mental health evaluation. We're in contact with the courts on some of those people. We're trying to get them into services outside of our facility. And they've actually done a fantastic job in getting these people out of our facility, because sometimes, regardless of what we want to do to help, sometimes that help is beyond our scope. Some people need different type of assistance, and we can provide that in our current facility.
All right, I don't have any questions in the interest of time.
I just have a quick statement. I work with people who are incarcerated in your county jail, and I have heard the vast consensus is that the conditions have greatly improved for them, and that they do enjoy their time out of their cells. Like when I have been incarcerated in that county jail, we were talking 20-hour lockdowns for the female blocks. Right. And also it's really, I like that you're mentioning the fact that the frequent flyer thing, because whenever I would leave there, oftentimes guards who are maybe still employed with you guys would say, see you later, see you soon. And it was a joke, and I don't know that those guards are still employed there, but I have had experience where a frequent flyer was a joke. So I appreciate you addressing that.
Thanks. April.
Thank you. I just have a few questions. What current positions do you have that can prescribe antipsychotics, and how many hours are they in the jail?
I didn't hear the first part of your question.
What current positions do you have in the jail that can prescribe antipsychotics, and how many hours do you have them in the jail?
We have one person that can prescribe that type of medication. I don't know specifically if it's antipsychotics, because some of those are forced med orders. A lot of the time, we have individuals who do not want to take it, and without a judge's signature, obviously we cannot. What was the second part of that?
How many hours? So what is the position?
It's 4 hours. We have a licensed clinical social worker staff of 2 people. And then we have a mental health social worker specifically who is prescribing those type of medications. Only 4 hours.
I think you have a nurse practitioner with prescription
A nurse,
authority.
a psychiatric nurse, right? And that's 4 hours a week.
Mhm.
So one of the positions you recommended was an additional qualified mental health professional. Can you tell me how that relates to, especially when we're talking about mental health? One of the things you talked about is having someone evaluated. I'm not sure what position that you have presently that can do that mental health evaluation and then prescribe medication according to the evaluation. Is this additional qualified medical health professional, does it cover any of those tasks?
Yes. So what we're really looking at in that position is 2 things. One, to get the proper evaluation and analysis upon intake, and really direct them through the facility, through programs and other things we have available. But more importantly, we're really trying, we've got 2 people right now that work tirelessly on a daily basis. And actually, I would say they're not officially off work anytime that they leave the facility, because they're continuously having to work with these individuals and what they need outside the facility as well. But part of the issue is we're reactive. I think that is the primary issue that we have. So when we talk about group counseling or just peer-to-peer or just one-on-one counseling, we do not have that opportunity, especially with only 2 people. We've got those 2 people are speaking to these people on a daily basis that are part of that mental health work. We're trying to provide them different avenues. Sometimes it's just getting their medication corrected. Sometimes it's speaking to the courts on their behalf. But really, there's not a lot of proactive work that they get to do on a daily basis. So we believe that an additional social worker could help mitigate that issue.
And when one is not available, that puts tremendous amount of pressure on the one that's there. And obviously we're worried about someone burning out and other people that are there not getting the service that they need.
And then my last question is about medical services. I know when we talked actually last week in our DEI conversation, we talked about access to medical care. How many hours is a doctor or medical service provider per a week available? Because I know you're dealing with a very large population. I mean, for the amount of services you're talking about, checkups for things that might be infections, emergency urology, gynecology, daily types of needs and emergent situations that you're dealing with. I was just wondering, how many hours are we talking?
So we have 88 hours pay period available to us per our contract, but we have those people available on a daily basis. So a doctor specifically is only typically utilized when needed. That's provided through our contract, but we have nurses on staff for that 88 hours, 2 of which I think there's 6 total, but there's at least 2 a day depending on the time of day, to pass medications, to follow up with sick orders, to check up on skin diseases or whatever else observation requirement is there. So on a daily basis, we provide medical care throughout the entirety of the day. So,
And if I remember correctly, the amount of hours that they work is substantial as well.
yes, well, and when we first came in, each person was working 14 to 18 hours a day. And we actually had to talk to our contract and say, hey, we've got to get some help with these people here. They're working tirelessly, and they immediately rectified that. So.
I think we have to move on to the next topic, but again, thanks so much for being here and sharing all of that with us. Next, we have Leah Scott, who was online and with Pinnacle Treatment Centers. Welcome, Leah.
Hi, good evening. So do you mind if I take over? I'm gonna share a slide deck.
Should be able to share. Yeah.
All right. Can you guys see my screen?
Yes.
Okay. So like you said, thank you. My name is Leah Scott. I'm the Executive Director of Recovery Works Martinsville. We are affiliated. Pinnacle Treatment Centers is our the DVA, so we're the Martinsville is our name under Pinnacle. And I want to start out with a video of our CEO, Joe Pritchard. He's in recovery himself, and I think this speaks volumes. The video is only about 2.5 minutes, but it speaks volumes to what we do and why.
We're not able to hear
Nope.
the video.
You can't hear that?
Yes, when you share, when you share your screen, and then select what file you're sharing, or what window, there should be an option to share audio, just a little click button.
Not me.
So you might have to stop share and reshare.
Okay, I will do that. Give me 1 second. Stop. Share screen.
Down at the very bottom, it says optimize for video.
Oh, perfect. Okay.
Then share sound.
All right. Let's see. I think. Let me know if this works. Can you guys hear that?
I think so.
Everything that I
able to hear?
wanted in life, everything that I was working towards was falling apart. My life came to a point where I saw no other option. Went into the military, into the Navy when I was 18. It was in an active addiction until the age of 20. Fortunately for me, I had some folks that saw the deterioration going on and reached out and intervened. And as a result of that intervention, I was able to get into treatment. And I really started to have a passion for helping others to deal with substance abuse issues. I'm Joe Pritchard. I'm the Chief Executive Officer for Pinnacle Treatment Centers. I've spent my entire life, my entire career, focused on providing the very best in care for substance use disorders. Individuals suffering from addiction face that illness head on multiple times. When they're alone in a room, no one around, they face the fact that their life is just being destroyed. Addiction doesn't really care about your lifestyle background, how you grew up, where you grew up. It affects everybody equally. And that's what frustrates family members and friends, because we sit back and think, well, why don't they just stop? It's an illness, it's a disease, it's a physical illness that affects that individual physically, emotionally, and spiritually. 25 to 30 million individuals suffering from substance use disorders. Only 15% of that population are seeking treatment. It's important that a treatment provider such as Pinnacle embeds themselves in that community, helping them understand what addiction is, helping them understand what treatment can do, beginning to give them the right information. We integrate 12-step recovery supports, medication-assisted treatment, family intervention to a residential setting that gives you a 24-hour support environment. That individual seeking treatment, that family member trying to get treatment for their loved one, that employer who has a valuable employee that's being rocked with this illness. It doesn't really matter who picks up that phone to get that individual help. Just pick it up and get help. Everybody's job here, from my job in helping to lead this company to the person that picks up the phone when you're reaching out for help, our only commitment is to give you an opportunity to access care and to turn your life around.
So I wanted to start with that just because I think for Pinnacle, it starts from the top up. I think it's powerful that our CEOs in recovery, it shows that we understand. A lot of times patients come in and they really say, you know, you don't understand, you don't know where I've been. And I'm proud that in recovery, we hire a lot of people in, like at Recovery Works, we hire people in recovery. It does make a difference. Our vice presidents in recovery, and I think from the top down, we try to keep that in mind, that they're people that just want to help. So things to remember, you know, the addiction is a disease. It's not a moral failure. It's not a character. I always tell the patients when they come in cussing us out, that's not who they are. Like once we get them in treatment and give them the help they need, that's when they can shine. They're stronger than, you know, there are days I know my patients are stronger than I am. I just got to get them to that point. So that's, you know, that's powerful. What we do at Recovery Works. So Recovery Works Martinsville, we wanted to do something different that's not been done yet. So we wanted, what I'm showing you guys is the ASAM continuum of care. So I know a lot of you guys, we know that there's many different levels of assistance, but it all depends on where the patient's appropriate and what will they take. So a lot of times I might want a patient in this residential level 3, but they say, back to, you know, one of the previous speakers, I don't have childcare. I can't quit work for 30 days. So all they can do is this level 1 outpatient. That's fine. You know, I would like them to have that higher level, but again, let's get them in any door that the patient will take to get them started. At Martinsville, what's different on our campus is that our goal, once we're done building everything, is to have all the levels of care. So we really wanted, you know, right now we have a 64-bed residential. Our partial hospitalization program is up and running. Right now I have about 35 in it. They live in our apartment complex in the evening. So our recovery homes, they stay with us for about 30 days. We can hold up to about 100 in our recovery houses. We just haven't expanded because we got to get the staff. We got to staff up before we expand from the 30 to 100. And then on campus, we also have an OTP, which is an opioid treatment program. That's the first of this kind, as we wanted to encompass a methadone clinic on the campus too. So we could truly surround the patient in all levels of care. If they needed some kind of MAT services, we can provide outpatient MAT services. What we don't have open yet, is our IOP level. So that's coming down the road, but we do have some local IOPs that we refer out to. So we just wanted everyone to know the differences in level of care and what's appropriate for each patient. Something for everyone to keep in mind is that relapse can happen at any stage. So whether the person's in detoxing, residential, PHP with sober living, which is what we have on campus, IOP's not open yet, OTP, and in self-care. So these are, as the patients are going through the care continuum, we want them to keep going to AA classes, NA classes, MARA classes. So something new is MARA. I know that if I send a patient who is taking medications to help with, if I send a patient to AA who's on a MAP program, it doesn't work well because AA is pure abstinence based versus MAP program, which is utilizing medications. So it's really putting the patient where they need to go to be successful. I always tell patients here at Pinnacle or Recovery Works, we don't just do 12-step. We don't just do NAAA, MARA. We want to show every way to recovery and then let the patient decide what's best for them. So that's my goal, is to add more tools to their tool belt while they're with us, give them the tools to take on whatever may happen once they leave our doors. But at any aspect, relapse can happen. So we want to fill their toolbox of tools while they're with us. Things to keep in mind that was brought up is after, when I have the patients at Recovery Works Martinsville, it's about 28 to 30 days for residential. And then it's again about another 21 to 28 days for PHP, so partial hospitalization. But what happens next? That's where the big key component is aftercare to help keep them in recovery. We always tell the patients here, this is their first step to sobriety, but this is a lifelong journey. So that's where working as, working together to really, handhold, coddle the patients to get them through their first couple of years is important. So just sober housing, medication, dental vision. I mean, when we see our patients, they're seeing dentists or, a primary care sometimes for the first time in 5, 10, 6 years, it's all over the board. And those problems that they have suppressed while they were in active use, now once we get them clear-minded, it all starts compounding on top of them. So we try to work with the patients on taking it one step at a time, but we get them clear-minded and now their life problems come back. So that's where our discharge planners are really trying to look holistically to say first step, second step, because, if they were in active use for 30 plus years, there's a lot that we got to catch up on. So I just wanted to really, let me stop sharing. I wanted to share these slides just to start out with what we are, but then kind of how do we, once they graduate the program, what's next? Because it's a full, to truly get the full continuum of care, our program's only 30, 60 days. That's just the first step in helping our patients and keeping them in sobriety for a lifetime. So I just wanted to open it up. I was trying to keep it short and sweet. I did want to let everyone know, at Recovery Works Martinsville, we go for both sides. So abstinence space or MAT, so medication assisted treatment. So Suboxone, Subutex, methadone, and all the above we accept. But then if they want abstinence space, absolutely. Transportation came up a lot. So just for you guys to know, we hire drivers and then we also have a third party. So if transportation is an issue to get patients to treatment, let us know. We have actually found it's easier for us to go pick up the patients because I assume that they're under the influence. They're coming to us, they need help. I would prefer them not drive themselves in. And then secondly, turnout rate. It seems to turn out better if we go get them versus waiting on the patient to come to us. So we have no problem driving, all around the state to grab patients. And then something to keep in mind too is what we're starting to see with insurance companies is they're kind of starting to push back now. So if patients have been in treatment 3, 4, 5, 6, 7 times in a year, they're starting to deny patients. They're saying that they've gone too many times, which is absurd because I know that the average time in treatment is about 4 to 5 times before it sticks. So we're really pushing back on insurance companies right now to say, I don't know how long it might take. It might take 12 times in treatment until it sticks. So it's not for us to determine. It's what works for the patient and to keep working with them as an individual. So kind of know that we're working with them, but we are getting pushback from the payer side of it too. So any questions, I guess? I want to open up the floor to, what treatment looks like or what's a typical day here. I'm open for any questions.
Thank you. I appreciate you sharing what you all do there. I will ask my colleagues. Do you have questions to my left?
Ms. Scott, thank you so much for your patience and sticking around. It's a long day for you, I'm sure, but we appreciate you giving your presentation. My first question is, the location in Martinsville is not the only Pinnacle location in Indiana. Is that correct?
Correct. We have residential and PHP in Maryville. So that's up north near Chicago area. In Cambridge City, that is in, it's about 30 minutes outside of Richmond.
Okay. And in terms of the referrals to the way that clients get to Recovery Works is, I think we've talked about, you do court order, you go and pick people up. But I think if people are interested or they need information, what's the best way to get a hold of your staff or your intake specialists?
So we have a 24/7 call center. So they can, look online, and I can share that number with Recovery Works, and they call our call center, and then we're talking in that moment to them. If they say, if we have an open bed, so when someone is saying beds, that's a true statement. With, I think in Indiana, the state shut down close to 300 beds, and we felt that. So with, was it Landmark or some company had to shut down, that hurt our patients. We definitely, sorry, I gotta plug in my computer before it dies. So that, we try to get our patients in ASAP. I know Monroe County Court actually does really good. We work with their sheriff department, and we get a good number of patients from Monroe County. So,
yeah,
we are thankful for that. But the best way is through the call center, and then they will talk to the patient to say, if I don't have an open bed here in Martinsville, let's get you to Maryville, let's get you to Cambridge, let's really work with you to get you. And if we don't have an open bed, they're not going to just drop the patient off there. Then our patient navigator, his name's Ryan Thomas, we send him out and we start looking for other beds in the state. So at this point, with the amount of beds that we don't have, we really have to partner with the other treatment centers together to say who's got open beds right now.
So again, we've heard over and over again that one of the barriers to care in the recovery space is space, number of beds.
Absolutely. We stay pretty full. If I'm not full, it's because I'm holding off, just honestly due to staffing. We have a counselor crisis in Indiana. It is hard to get enough counselors. So that would be the only reason I hold off beds, is if I don't have the clinical staff to support it, because it's quality too. So I can open up all these beds, but if they're not getting the quality care, our patients, they need to see their counselors. They need that individual session. So I push back a lot to make sure that I have the staff to support them. Because if not, they're just going to groups, and they're not going to get that individualized treatment that they need. We are hopefully opening another 32 beds in Martinsville. We partnered with IU Morgan. So we have the top floor of IU Morgan. So hopefully in the near future, we're in the process of hiring right now, I can open up another 32 beds. So in Martinsville, that should give us, what is it? 64. That should give us 96 beds in Martinsville for residential and detox.
Okay. All right. Thank you. I'll turn it over to my colleagues.
Are there other? Oh, okay. Go right ahead.
Wrong button. Hi, Leah. Linda Grove Paul from Centerstone. How are you?
Good. How are you?
Good, good. Well, I appreciate Recovery Works. I know we work with them quite a lot. Definitely, I think a bunch of the referrals that you get come directly from Stride. Been up there, we visited. And you know, it's definitely a great resource, particularly with doing the 24/7 admissions and also having the Cambridge City available. So it definitely makes a difference. I do have a few questions for you. I know you recently closed your psych hospital. And I guess, you know, I'm kind of bringing that up. It's a question, but it's also a little bit of a commentary in terms of, can you tell us a little bit about sort of why? I mean, I
Yeah.
kind of know the answer to it, but I think it's important because there's a payment point with substance residential that is getting people to continue to add more and more beds. You see continued expansion with substance residential because it's a generous payment point. Whereas with psych, and I know that's come up where people are saying like, hey, we need something psych that's like substance residential. Well, guess what? There is not a payment point that is comparable. And I think people that don't really understand the business don't really get that you can open a program, you can have it running. And, you know, my daughter was actually clinical director of that program that they closed 3-4 weeks ago because, well, and I guess I'll just say because of the census, right? So, I mean,
yes.
I think the issue is, again, I think we do make a lot of sort of assumptions of like, okay, well, we can build something and then we're going to be able to fund it. There's the resources that are available in terms of sustainability. And when people are saying like, okay, well, we're going to have one, you know, my question is, how are you going to pay for it, you know, long term, because it's not cheap. So I don't know if you wanted to say anything. Sorry.
No, yeah, I don't mind speaking on it. So it did. We put a ton of effort into it. We knew when we opened the psychiatric hospital, we really wanted the OTP, right? So an opioid treatment program, methadone, you have to be connected to a psych hospital. So we said, okay, this is how bad we want it. We know that mental health, substance, they go hand in hand, and it helped us. There were many times our psych hospital, our patients would be in residential or in PHP and become suicidal, homicidal, go in psychosis. And we were able to instantly move them from one part of the building to the other. But unfortunately, we kept it open for a good year and we could not fill the beds. And it was costing our company about $500,000 a month, half a million a month that we were going negative by keeping that one unit open. And it was, we wanted to make it 32 beds. We shut down those 32 beds and said, all right, let's make it 15 bed. Let's get 15 beds full. We were not getting the referrals. We were not, they weren't full. We would have anywhere from 4 to 8 patients at a time. Maybe the most we ever got up to was 12. And then, but we were waitlisted on residential and waitlisted. So finally we had to make a choice.
And what would the average length of stay typically be for
5 to 7 days? So it was not long term.
And that's the other thing to kind of keep in mind is when you're looking at what would get paid for, unlike the substance residential, where you're looking at 23 to 28 days, you're only looking at 5 to 7. So you're looking at a lot of patients that are coming through as well. Sorry, Leah.
No, and that was hard. I mean, our staff, that was the hardest thing I've done here is opening a unit within a year and then closing it down about a year later. And that's not what we wanted. I know the needs out there and I'm not sure why, you know, I don't know. I don't know where. We know the patients needed, like you were saying, they need long-term psych care, but to make sure for that acute, you know, to get into an inpatient psych hospital, you have to be suicidal, homicidal, or in psychosis at that moment. If they come out of that a couple of days later, insurance instantly denies them and says they got to go somewhere. And what we need is that long-term. We struggled with discharging for long-term psych needs because they're just not ready.
And again, there's really some advocacy that has to go on at the state level to really say, I mean, Medicaid waiver. I mean, that's how the substance residential happened. It's an 1115 Medicaid waiver that will actually pay for that. So thank you. I had one more question related to that. Was your detox component associated with that hospital, or can you guys still do medical detox?
So we could still do detox. We do. Now, obviously, we don't have, like, if they need IV fluids, we'll work with IU Morgan. We send them out to get fluids, and then they bring them right back. So we don't
But you
do the
can do
banana
medical
bags.
detox?
Yep, we can do the medical
Okay.
detox.
Okay, great. Yeah, that's helpful. And then I think the last thing I just wanted to say in terms of the aftercare, because I know with the substance residential and then that 30-day stay with the partial program is, about 28-30 days, which, I understand that's kind of the amount of time that insurance will pay, but that's a pretty short transitional. You're really only looking at a month as opposed to typically most transitional or a minimum 3 to 6 months. And I know you mentioned aftercare, but also sober living. Is there sober living on site?
No, so our apartments are for our partial hospitalization patients. Now we are, we work with Oxford Homes closely. We send patients to now counseling down in Evansville a lot because they have housing plus IOP. So I think that's the next thing that we know our patients really need is that IOP level of care with housing, because the homeless population is so large that even to get them into Oxford Homes, you have to have a couple hundred down, and they don't have it. So a lot of times we're trying to help them. We're working with local churches to see if anybody can help waive those admission fees. But that's the next step. A lot of people have asked, can Pinnacle buy in to get another apartment complex for transitional? I'm not saying no, but we're saying we're working on getting stabilized with what we have. But yes, housing is necessary for transitional.
Thank you.
You're welcome. Thanks.
So much.
Oh, sorry.
Go ahead.
I just have a quick question. One of the hardest people to place that I work with are people with sex offenses. Do you take folks who are sexual offenders?
We do. Now, here's the stipulation in residential. Yes. We don't even ask. Obviously residential, yes. Now, PHP, our partial hospitalization, if they're a child, if they have to register as a child sex offender, our apartments are close to the high school, so I can't register them. So that's where we get into trouble. In residential, absolutely, they can come, they can register, no problem. But if they go to that next level of care, the PHP, that's where we get in. It's hard because I can't. Pinnacle doesn't mind, but it's where our apartments are located. It's too close to the school.
I've had really good luck accessing Pinnacle for treatment for folks with pretty low barrier. Do you take folks who are on house arrest as well?
Yeah. We just say plug in into the group room, go to group.
Plug in.
Thank you so much for coming.
Yep.
Well, plug in.
Find a cord and let's go.
Thank you for sharing what you do. It's an interesting model and something I've heard a lot about, but not really known a lot about until today. So appreciate that. We probably do need to move on. So I am Linda, you are up next.
All right, sounds good. And I do have a presentation as well. I'm not sure if Courtney's pulling it up.
TSD, do you have that? Or Courtney has it.
And, by way of just kind of going through the presentation, I know both Courtney and Peter, 10 to 15 minutes. Definitely want to stick with that. There's a lot of information, and I think part of it is having not been involved in some of the earlier discussions, not really sure exactly what it was you wanted. I think initially it was like, oh, let's talk about treatment continuum. So definitely did some information there, as well as then, some recommendations. So I'm going to zip through this, and then Courtney, can you see me? Can I just point for the next slide when you need to do the next slide? Okay, great. All right, go. There we go. So I think, the issue really is the complexity of the individuals that we're talking about. And I think that's really kind of what I want to drive home is the individuals where, yeah, they can just go into treatment one time and they're done. Whether that's mental health or substance, those typically are not the people that we're seeing. We really are seeing people that are very complicated, that have needs in multiple facets that we have to be able to address. This is just a PowerPoint slide that basically talks about all of the components of care that we provide. It's difficult to have on a slide. There's a lot of things that aren't necessarily there, but I think that idea of prevention, early intervention, treatment, and recovery, and all of that really has to happen in tandem. And you're talking about medical, psychiatric, we have an FQHC, medication-assisted treatment, making sure that we're engaging. We have 6 staff that between the PATH grant, the homeless grant, and downtown outreach that just do homeless outreach. We have a federal grant that is just doing homeless work with really great outcomes, but it's just a drop in the bucket when you think about the needs that are here in our community. So next slide. And part of the reason I put all of this information together is a lot of people don't know much about Centerstone, and I really wanted to just kind of put some information up that I can put out, and then people can ask more questions because there's a lot. So in the last year, 2022, we served about 4,000 Monroe County residents. About half were self-referred, 18% by healthcare entities, 13% by the courts and criminal justice system, 83% are adults. Probably about 15% of those are children, and higher than that is the rest. Medicaid paid for about 60% of our services. There is a relatively small commercial insurance. A lot of folks healthy, one of the Healthy Indiana plans. 30% had no insurance at time of intake. And again, as I said before, almost all of those folks are eligible for insurance. And, I'll say, just as you heard the Recovery Works or the Pinnacle treatment, that's kind of, part of my scratching my head with a lot of people when they talk about treatment fees is really all of those things. If you are Medicaid, that should 100% be paid for. There should be no copay. Sometimes there has, kind of that small amount of $100 a year, but, places like Centerstone have a fund where we're able to pay that for individuals. Next, please. So this is really just kind of looking at, overall, basically we got to work in conjunction together. And when you look at all of those points of the criminal justice system that individuals come in contact with, basically they potentially need all of those things that are on the right-hand side. And I think, the point about that is, we in all of those areas, those are areas that we cover. Even, when the lady at Pinnacle was talking, we have that same substance continuum. We have medication assisted treatment, we have substance residential, we have IOP, we have IoT, we have that outpatient continuum. The thing that really matters though is that people need to be connected as providers together. And I think, as we talk some about the jail services, if we don't work well together, if we as a community don't collaborate, we don't communicate, we don't have access to one another's information, we're never really going to do people justice, because otherwise they're just kind of coming in and out of the silos. So I think that's really the gist of what I want to make here. Next, please. Already talked about the Crisis Diversion Center. Just put that in there because I want people in one place to have all of the information and the numbers to reach, and how to access. Talked about the data of the people that we've served. Actually, Stride is just hitting the end of their 3rd year this week, and we've served 3,400 guests. So excited about that. And as we said, in terms of getting people in, we're taking people to Recovery Works in the middle of the night. We're transporting people to psych hospitals in the middle of the night, because if somebody comes in and they say, I want to go now, then that is really the way that we're able to get them. And now that we have our mobile team, it's made a huge difference. Next, please. I think just the other thing is recognizing how vulnerable people are now more than ever in terms of the risk of overdose and the risk of suicide. It is just absolutely off the hook. And I think, we certainly screen everybody. We have, what we call an overdose pathway. So someone who is particularly vulnerable, maybe they're using, some sort of an opioid, or they have a history of overdose. We really want to make sure that we're talking to them about the risk of them potentially dying. And we want to do everything, whether it's, making sure that they have naloxone on their person, that they're not using alone, harm reduction. What are the things that we need to do to ensure that people are safe? Same thing's true with suicidality. I know in Owen County recently, there were three kids in school who attempted to kill themselves. 2 were successful. And that is in the last month. And, when I say things are, I can implore you, and it's not just people who are, in the criminal justice system. These are regular folks that oftentimes have a lot of, problems in their lives, but that's not necessarily the case. And so as we really look at our system, it is we've got to do a better job of diverting and getting to people earlier. And that is, again, sort of that plea. You don't want people to come into your jail. You don't want to have to work with that. So how do we do a better job of making sure that we're doing more early intervention? Next, please. So again, probably more information than what you want, but when you think about people with serious mental illness, they need to be able to get into services right away, same day access. We do intakes from the hospital. We work with IU Health very closely on lots of different things. We have a drop-in center for Horizons. We have life skills, case management, an ACT team, FACT team, which is assertive community treatment, forensic assertive community treatment, employment assisted, including supportive employment, connecting people with healthcare, FQHC, on-site medication, crisis services, and specialized home housing services. So I think just recognizing how much people need depending on where they are. And as you talked about some of the people that you guys are serving, people are on a continuum. There are people that really, they need somebody to take them their meds 3 times a day, or they need to be on an injectable that has to be monitored in order for them to stay well. Next slide, please. And other people that don't need that level of care. Just mentioning, sometimes I think people don't necessarily know, clients that are on commitment, how commitments work. Centerstone, Meadows, IU Health, will all potentially accept people who are on commitment. And, again, when you look at what is the threshold for that, it is a person who shows a grave threat to themselves or someone else. So that is not something that the courts or the people here take lightly. And right now we have 35 residents that are on outpatient commitment. And then just, it requires review as well as, trying to make sure that they're compliant with the medications they need to take and the services they need to have so that they don't decompensate. The other thing is just the gatekeeping. Basically, anybody who goes into a state hospital has to go through a community mental health provider. You can see we only have 9 people. When you think about the severity of the people in our community, do you have any, you guys probably know how hard it is to get somebody in the state hospital. It's very, very difficult. It's next to impossible. So, 9 people, not a lot, but when somebody does go to the state hospital, we have to do a 30-day assessment on them at the hospital. So we go to the hospital, we meet with that person, and then we're meeting with them every 90 days until they come back into the community. And then we're really responsible for making sure that they get back into the community and are in housing. And I know, met with you guys to just talk about how important the housing is for people who are really struggling. So, really want to make sure that folks kind of recognize that role as well. Next, please. We have a lot of supportive housing units in the community. Just kind of mentioned that specifically for people with serious mental illness. And then housing for homeless, we have 95 units. Also mentioning, the PATH program. So in the last year, we've worked with 511 individuals just with PATH program. And that's one of 3 that we're working with. And this is, homeless or at risk of being homeless. Also, FHHC is finding home, health, and community. That's a SAMHSA grant that we had, 300 people enrolled, all homeless or at risk of homelessness. 77% have obtained stable housing. And I say that because these people are not people who necessarily have resources to housing, right? This isn't housing, and it's critical time intervention is, kind of the evidence-based protocol that we use, but it really is saying working intensively with people to help them get into housing really can make a difference. Next slide, please. So specialized services for substance disorder, again, same day treatment. We do have some dedicated intakes for jail and problem solving courts to get them in and, make sure that we're getting them in a timely fashion. It's called Peer Run Drop-In Center. It is the Peer Run Center. It's over on First Street, and it's primarily for individuals with SMI, but it's run by peers, and it's just a drop-in center. And we have lots of people coming every day. It's a support for those individuals, as well as, people who are struggling with mental health or substance issues. Also therapy, recovery coaching, health, residential. We obviously have employment services. I'm going to give an example about that. Nursing and health coaching, pharmacy, psychiatry, medication assisted services, and crisis services for all of our substance folks. Next slide, please. And then, any group individual. So this really talks about our residential program. So, this is kind of what I'm saying in terms of the 28-day program. We have 49 beds, 21 are for women, 28 are for men. In the last year, 200 Monroe County residents have been served. And 74% have graduated. I know that we actually, some people have asked about transgender. We've actually taken several transgendered folks very successfully. We've also worked with a lot of people who are on methadone, and that is unique because there are a lot of treatment facilities. In fact, the vast majority are not able to take individuals who are on methadone. So we have done that successfully. High risk. So 91% of the people that we serve are unhoused, right? So, when you look at the vast majority of the individuals that we're serving in our substance residential, they don't have housing. 100% are co-occurring, meaning not just a substance issue, but a mental health issue as well. 100% or 200% or below poverty levels. So, we're definitely talking about people who are very high risk, very vulnerable, and have a lot of complex needs. For pregnant clients, 28 from the courts. The other thing I'll mention, and I know, Leah talked a little bit about insurance companies not wanting to pay for, treatment again and again. And I will tell you the flip side of that coin. And that's kind of one of the things that I was saying as far as, recognizing that, there are a lot of people who are going into that system and going into that business. Is I was talking to Anthem because I was getting data for Stride, and I was saying, I'm confused. I'd really like to see the outcomes of our people who come to our substance, residential, and then do our outpatient or our transitional, our substance transitional housing, which is about 3 months afterwards, and see, how those outcomes fare. And she said, Linda, when we're looking at our data, she said, probably, I think she said maybe 3 or 4 times is the average amount of times that people are coming into substance residential a year. A year. And she said, and more disturbing is that the follow-up for the individuals for one appointment post-discharge from a 28-day facility, and this is all through the state of Indiana, right? So there's like 2,800 beds at this point, is 7%. Let that resonate. So, you know, if and Recovery Works Pinnacle saying, hey, we want to make sure we have the continuum. We want to make sure we're getting them in. You know, they're definitely a good guy, but it's a racket. And there are a lot of people who are just going in, they do that 28-day treatment, and then they go, I mean, it's not that different from going to jail. You go in, you're there. If you go back out, if you don't have a warm handoff, if you are not connected to services, and housing is the biggest issue, especially the transitional housing. I know we've talked about that, but the real key to people being successful, and especially being successful in their community, most people want to go back, but we don't have enough transitional housing, and the funding available for that. I mean, you know, we're hopeful it will happen, but that is probably one of the greatest needs that we have. So I want to put a plug in there, but I also want to give you some context when you think about, you know, insurance companies saying, well, yeah, we don't want to put this person's been here 5 times. Well, what is the follow-up? And who are the providers? Because there really are people. And, you know, when she was talking about Landmark, I mean, I don't know if you guys read about what happened at Landmark, but 4 people died at Landmark Recovery Center up in, you know, the northern. They died of overdoses and they weren't being watched, and they shut down all 3 Landmark facilities about maybe 6 weeks ago. Maybe the 4th person didn't die, but within a week of each other at that facility. So, you know, I think it's important to understand too, not all treatment facilities are the same. And, you know, you really do want to make sure that, you know, that you're looking at it. Anyway, next slide. Sorry. This is going to take my time. So you've got the data. So our CRT, so we do have transition for men and women. 75 men have been admitted, you know, problem solving courts, 88% graduation rate, 99 days on average is how long those folks are saying. You know, it's important for people, especially in transitional, to have a longer length of stay. Short term to kind of get the basic information, but as you're transitioning back into the community, it takes time, it takes money to, you know, be able to have some resources. 100% homeless, 100% co-occurring, 100% to, you know, so those numbers are pretty high. And with the women, you're looking pretty much at the same data. Next slide, please. These are evidence-based curriculums and interventions and treatment that we use. We only use evidence-based curriculum. Next slide. And I don't know, Ashley, if you want to just spend a minute talking about Cork and the Cork data.
Yeah. So I'm Ashley Collins with Centerstone, and I'm the program director and manager of the Cork grant. On Friday, it will be the last day of our 3rd year. So on September 1, we begin our 4th year. And these are some, this is some data about that. So there's 62% of people, and these were just Monroe County. So I had them pull, like, we're in 9 counties. So this is just Monroe County data. So 62% increased employment from intake to 6 months. 44% drug use decrease from intake to 6 months. We also have been really working hard through the Cork program of getting naloxone out to the community. So we have the vending machine that went in April of, I guess that was 2022. And we're also working on
in the jail.
Yeah, it was in the lobby of the jail, which was huge because people are really high risk of overdose coming out of jail, out of residential treatment, out of, you know, anything where they were conditionally sober for a period of time, puts them at high risk for the overdose.
Hospital.
yeah, we're working on getting naloxone in the hospital that will run the nalox box. I've also been working with Steve Cover, Deputy Director of the Monroe County Fire Department, and we're going to install 7 nalox boxes in all the local fire departments. It came up in our SOFR meeting, the Suicide and Overdose Fatality Review meeting, that all the naloxone that's available is really in downtown Bloomington. So we really want to be able to reach more of those rural areas. And some of those places don't have very many businesses, but they have fire departments. So, and turns out some people that are overdosing are going to the fire departments when they're out that far anyways. So helping to support that, but really expanding access to MAT. Linda mentioned a huge project that we did under this grant was getting to a point where we had policies and procedures to be able to accept people at a residential facility that are on methadone. And we were the first to do it in the state of Indiana. Before we did it, that level of care was not accessible to people that were on methadone. They were told they had to stop taking the life-saving medication to be able to go into that level of service, which is disgusting and ridiculous. And then Pinnacle is now the second one that does that. And I think they do all of their stuff in-house, but we've been taking people from OTPs like as far as like South Bend. And
because if somebody comes to us and they're on methadone, they can only have a 14-day supply, and they will not give us or anybody else the methadone. So we have to drive them. So if they're in South Bend and they're a substance residential, we have to physically take them up to South Bend to get the next 14 days.
Yeah, and so we've been coordinating all of that transportation. So at the halfway point, my staff will take the client back to their OTP to get their next set of doses and take them back to treatment. And the same thing at the end of treatment, going back to the OTP for turning in their empty vials. And we've been there's an OTP symposium that's been going on, a tour in the state of Indiana. There's been 4 of them now. And myself and my boss, Jennifer Fillmore, have really been encouraging other community mental health agencies to be doing the same thing with the residential facilities, because we need help. We only have 3 residential facilities. There needs to be a lot more places for people to go when they're on methadone. And yeah, so we've seen a lot of really amazing results. My team is made up of mostly people that are in recovery themselves, and really helping them connect to the recovery community that they're in is huge.
And I will say that, part of this is, this is a SAMHSA funded. We were the first of 4 in the nation that were funded. And the idea is to create kind of a comprehensive opioid recovery center, and it's to coordinate. So we work with Clean Slate, we work with groups, we say people, any of the recovery works, any methadone, if somebody wants to get on, Suboxone or methadone, we don't have the resources, we're going to get you to somebody who does. And again, it's that collaboration and coordination. You're seeing some people really do some amazing work there. And I think that's a perfect example of the kind of stuff we need to continue to do. Next slide, please. I swear I'm getting close to done. This is health, our integrated health. So it's really important, I think, to recognize, just the fact that we are moving towards, certified behavioral health clinic. CCBHC is something you may not have heard of, but the idea is really transforming how community mental health is working. And with that, it would be wonderful because it would move us away from fee for service to, I know, we'd be thrilled to, a method that's really based on outcomes. Also have a federally qualified health clinic. So really making sure that we're comprehensively taking care of the care of our patients, because we know people, especially with serious mental illness, die 25 years before the general population. So it's a significant issue. Next slide, please. So I just want to take a minute. I don't know if the mayor's on still, but I know he mentioned this program a while back, but this is a great, exciting program. And I want the county to get excited about it because I I can't think of anything that brings me more joy than this particular program. And it started in 2017. Okay, Crisis on Kirkwood. Anybody who was around, you remember it. All of the people overdosing on Kirkwood. Thankfully, it was spice. It wasn't necessarily lethal, but you know, it was very visible. And people in the community came together and said, "Gosh, you know, we gotta really start doing something." And that was kind of the inception of Stride as well. Well, one of the big things was like, we got to make sure we're keeping our parks clean. We're going to keep Kirkwood clean. You know, you saw more people talking about, you know, this and that thing, but just more trash. You know, there were just, and there was a huge increase in people who were unhoused. So it was like, hey, what's going on? And at the same time, places like, I'm sure you guys have struggled with this as well, but they couldn't staff, you know, kind of menial positions, you know, so you're looking at somebody who's picking up trash in parks, not necessarily interested. And they were like, hey, would you guys be interested in helping? And we were like, absolutely. Wrote a grant, worked with Community Foundation and the Health Foundation, and, you know, got funds for an employee to work with them. So it is a supported employment. Since we started, we have employed 122 individuals. Started as, you know, very part-time seasonal work, doing something they couldn't find anybody to do. I think, you know, I think our budget's maybe around $275,000 a year. Like, we're providing a lot of people. You look at people picking up trash in the parks. And the thing that's so cool, and I go out with them, put on my orange vest, pick up trash, you know, you go to, you'll see them everywhere, go down to Switchyard. And the thing is these are people, and it's very much an employment first model. These are people who maybe are still actively using. We're not necessarily requiring that, but they can talk to the people that they're helping, you know, proselytize more than anybody else. They're like, oh my gosh, you did it. You've got a job. I really want to do that too. We have not had any problems hiring people. We constantly have, you know, a wait list of people who want to come work for us. And again, many of these people have been in active use. As you can see, 72 of the 122 were unhoused or in transitional housing. 100% of those unhoused people got housing and working with the program. So they worked with them and staff worked with them. Currently, we have 30 employees. One individual who started the first crew now coordinates the program and has maintained employment for 6 years. 7 are obtaining their peers, or have obtained their peer certification, continue to help, you know, the folks with mental health and substance. And then I think, 35 have participated in substance residential. So what's that tell you? That tells you that people who really need substance residential are working, right? And then they're saying like, I need help. And they're working with peers. They're working with, you know, people who are really inspiring them. And then we hold their job. They go get substance treatment. We bring them back and we help them. So you know, when we think about programs to invest in, this is just such a great example of a win-win. And I know, you know, Doug Hunsinger from Governor's Office is coming down. We're meeting with them in a few weeks at the city to talk about this program, because nobody's really doing it. And you know, I've said to the city, like, we need to promote this more, because we have some pretty amazing outcomes. And again, this is just a great example of a win-win. Okay, next slide, please. So finally, just really, I know you guys have been talking about this, but I think it's really important as we look at the sequential intercept model and we look at treatment interventions is, you know, that 0 point, the crisis lines and crisis care continuum, as we've talked about before, that has not been available. This is a brand new service in the state of Indiana because it is not paid for. Now we have grants. We're lucky to be able to get that, but you know, not having that service is, you know, is really significant. Next slide, please. So last 2 slides, promise. But as we really think about the people that we have in our community, you know, how do they come, especially to jail bookings, you know, how long are they staying, connections to treatment, recidivism. So these are really sort of the 4 key areas we really need to be thinking about to improve, particularly people who are coming in contact with the jail system. Next slide, please. Okay, I think you're gonna have to keep pushing them. Thank you. All right. Okay, so as you really think about that, how do you get people to not call 911? That's the first thing, right? We are trained if they're, I mean, and by default, right? There hasn't been a crisis system before. What could you do except call 911 to get somebody there? But if somebody's just having a mental health or substance issue, you know, you're concerned about them, you can call 988. You can call Stride, you can call the crisis number, but people don't really know. And that's a place we actually have to put some resources. We need to really be thinking about how do we get that message out so that people know where to go to get help. I think also in terms of 911 is just dispatch. I think I mentioned, you know, a few weeks ago, they said, hey, our call volume in 911 is up 40%. Like, you know, and a lot of that call volume are people that don't necessarily need to go to 911. I know they're hiring or in process of hiring a social worker, trying to hire somebody. And all of that embedding is definitely good. The mayor's office has definitely been looking at, you know, what are some things that we can do to try to divert and partner, but resources, time, effort, energy, like this is really important. And it's almost like you guys were talking about transition team, really is that same kind of concept. We really need a transition team to say, how do we change behavior in the community? So those people that we're talking about, and, you know, again, in terms of examples, you know, somebody who calls mobile crisis, you know, oftentimes they need mental health help. They need to get into a treatment facility. They need, you know, maybe help with their kids. We can prevent them. We can get them into treatment without ever having to have law enforcement come out there, but people don't know about it. So it's definitely something important. All of these things, these recommendations, these are all part of, most of these are things that maybe we've done some of, but not enough. I'd say all in item 1, you know, police, sheriff, mental health collaboration programs, definitely something we need to do more of. Stride, diversion from prosecution. Our prosecutor has worked with us to say, hey, these are, you know, these 7 charges, you can divert. You don't have to, you know, call, you can just take them to Stride. And, you know, I think law enforcement has been empowered to do that. And I think a lot of people don't know the work that's been going on in our community in this regard. And I think it is important. In terms of just looking, you know, data, I mean, that's something I haven't talked about, but data is incredibly important. We got to make sure we know what's going on. As far as, you know, screening, pretrial mental health diversion, those things are already in place. But, you know, things like competency restoration. I'm sure you guys have some folks that are there. We need a solid program to say, hey, what are we doing with some of these folks to actually get resolution and move them to a more appropriate placement? And I think having all of us work on this together is a place where it's really important. Reentry planning. I know these guys have talked about it, and I'm really impressed with your passion and your presentation with the work that you're doing in the jail and the work that you want to continue to do in the jail. And I think that connection to treatment is so important. You know, sometimes the people who end up in the jail are people that we know, and we know the medications that they're on, and making sure that we're communicating and saying, like, how do we ensure that we keep as much stability as we possibly can, so that kind of that front end, as well as people who are coming back into the community, and not just Centerstone, but, you know, other treatment providers. So I think that program director, the reentry liaison, all of those things are like key collaborators and key community partners. I know you guys already heard about, you know, the drug courts and problem solving courts. You know, I think having access to mental health inpatient, I again kind of wanted to bring that up as an example, because I do think that people don't really understand the lack of resources. There are gaps in our mental health system, you know, you could still drive a truck through, and that is definitely a significant one. And then finally, you know, just a lot of the work on recidivism. So sorry, I know it took more than 15 minutes, but
yes, I was being reminded about the time, and as my colleague Councilor Crossley pointed out, this is too interesting to rush. So I appreciate all of that. Do we have a copy of your, could you send that to Could you send it to everyone on council, please? That would be great. Thank you. Thank you for that. In the interest of time, I'm not gonna do questions and I apologize. But just has been, it's very late and we do have Mark DeLong here and I'd like to hear from him. We've heard from lots of your colleagues,
Wherever
so
sits
yeah, wherever you'd like.
Okay.
Okay, that works too. So my, just to set the expectations for folks, I want to hear from Mark in your presentation. And then we will have public comment. I'm not gonna not have public comment. So for those who have stayed, we will have that. That said, welcome and thank you for your patience.
Thank you for the invitation. My name is Mark DeLong. I'm the director at Amethyst House. And Courtney, you got to help me out a little bit. So go ahead and change. Thank you. First off, I'd just like to mention the mission of Amethyst. Amethyst House mission is to provide a foundation for recovery by partnering with individuals, families, and communities impacted by substance use disorder, offering high-quality residential and outpatient treatment services and guidance for healthy living. A little history about Amethyst House. We've been in the community for 43 years. I've been here about 16 years now, and I think I'm the second seniority right now at our agency. But we love the Bloomington community. I feel like we're not only supported, but we're also embraced in the community. We like where the neighborhoods our programming is. We have 3 locations, both within about 6 blocks of the courthouse. We began in 1980 as a sober living program. In the 90s, we then extended to have a women's residential program, became a DMHA managed care provider in 98, CARF accredited by 2000. Big changes have happened in just the last few years. We've been a sober housing halfway house model for years and years. In 2018, we became approved as an ASAM 3.1 residential program. And that is a clinically managed low intensity residential program. So what that means is typically when folks get complete like a CRC program, a 28-day model, we will assess people to come into our program. Our program is then up to 3 months. It had been 6 months, but when we went to the Medicaid model, we typically are 3 months at this point. We get referrals also from the county jail. We have an admissions coordinator that goes into the jail regularly. We find that Medicaid does pay when we approve people and they meet ASAM criteria. We can get them into our program pretty seamlessly from the jail. Our admissions coordinator also travels to other jails, to prisons, to other treatment centers. A lot of times we'll connect with people in other treatment centers that are Monroe County residents, and we reconnect them at home in our programming. So that's pretty cool. We also began doing MAT in 2019. We started doing medication-assisted treatment. By that, I mean, we accept probably a third of our clients are MAT clients. We have a physician who consults with us who's Suboxone certified prescriber. We're hoping to expand with him in our outpatient office in the near future. Right now, he's not prescribing, but we had good relationships with Clean Slate Transitions groups and other MAT providers in the community. So, yeah. So with our residential programs, just to explain what we do, we have 2 residential programs, one for women, one for men. The big change in 2018 is we provide now 24/7 supervision. We have 4 case managers. We have techs that work. And we also have master's level clinicians that have offices at our outpatient office. So our residents typically have treatment in the residential settings, but they also have treatment at the outpatient office too. Typically treatment is 3 to 4 groups a week. Thursday nights is house meetings where they're very much peer-driven house meetings. And they're really good on for accountability and so on. Plus, we have a lot of 12-step meetings in our residential settings. So, and typically when our residents come in, they pretty much have to, even with the 3-month program, we wish it was longer. So often our residents come in right day one, we're starting with discharge planning. We're starting to talk about our model is such that they're out in the community, they find employment. So they're involved in treatment in the evenings typically, or during the day if they have a second shift job, they find employment locally. We start talking about housing day one because that's a huge barrier in this town, is finding some place where our folks can go to after 3 months. We're grateful for programs like the local sober living programs, Counseling for Change or Courage to Change, and also Oxford House, we utilize some. We also have some ways to find some financial assistance for folks for rent through South Central Community Action Program really helps us out a lot with that. So, but residents typically attend case management. They can have individual therapy, the groups and so on. One of the neat things we have, I want to shout out to Perry Township, is we have funding for what we call recreational enhancement, which it's funding that we can teach our residents how to have fun sober, because that's such a forgotten issue. So often people are either going to work, they're going to meetings, they're going to probation appointments, they're doing everything, but they really don't know how to have fun sober. And I think that's such a key component of recovery, is somehow getting to that place where you discover I can have some fun sober. So we have funding where people can put in for, we had a guy who wanted to take singing lessons because he wanted to get in choir in his church, or we had, people just want $50, $100 to take their kids to a movie and lunch. And maybe for 25 years, they've never connected with family like that. And we can pass on money to them to be able to do stuff like that. One of the things I want to mention, September 17th, this is a public invite. There's a recovery picnic that we're helping out with that will be at Bryant Park Woodlawn Shelter on it's Sunday, September 17th, all day, and it's going to be softball and barbecue and so on. So just mentioning that. Go ahead, Roll. And also I want to mention we have an outpatient program. We've been working to expand this. Our clinical director has been with us a year. He is a clinical psychologist, HSPP, and he's been trying to build up our trauma-informed care. We also take a lot of referrals for outpatient only, but a lot of our residents do some of their treatment through our outpatient office. And we have master's level clinicians there. We also have a consulting medical doctor, as I mentioned, that also helps us out there. And one of our goals is to get him expand into have a role where he can prescribe Suboxone there. So, so recently, this is past year, we have 3 clinicians trained in EMDR, eye movement desensitization and reprocessing. It's been really effective. Our residents love it. They keep coming back and saying, hey, this is really something that I didn't realize could really help me at this level. So, and we also began 2 clinicians trained in MRT, moral recognition therapy. And looking ahead, I mentioned we're trying to expand to have our physician helping us out more than consulting, but doing some direct service. And we're hoping we can find some funding for that. So, and just throwing up here some evidence-based practices that we utilize, where we also utilize stages of change. Again, ASAM criteria. We're not a halfway house. We're not low barrier where we can just take anybody in. They have to meet ASAM criteria to qualify for our programming. One of those ways for our residential to qualify, they have to show they failed at other levels, lower levels of care, and that they really need this level of care, this environment because they're going to an unsafe environment. So that works out a lot with the jail folks that come to us. So also I mentioned motivational interviewing and seeking safety we've been having at our women's house the last few months. So that's been good to have. So, and just kind of wrapping up, just talking about some program challenges. Probably our biggest challenge is we are kind of financially driven by HIP Medicaid. Our biggest issue is our HIP Medicaid will pay probably 24 to 30 days. And then a lot of times we'll get recovery works for potentially another 7 days. We're low intensity, so it's driven that HIP Medicaid is a per diem. It's not a very high amount of money. But we want to keep people 3 months. So that last 2 months, it's really a financial hardship for Amethyst. We have a set amount of people we want to have on Medicaid at all times, which is usually about a third of our folks. But really, it's a struggle. And I don't know, we've had for the last 4 years, last 4 years, we've had some gap funding through the state, which is going to conclude in September. It's coming to, we've reapplied, but the money that's out there is less than it's been in the past. So we'll see where that goes. But we really don't want to, but at some point we could be having to cut back to like 10 weeks instead of 13 weeks, 3 months. We don't know yet. We have a lot of residents come to us at 3 months saying, can I have another month? Can I, I had a guy come into my office who was with us in 2014 and did the 6-month program and was successful at the time. And he's at the end of his 3 months. He says, I really need that 6-month model. And I'm like, yeah, I know you do, but this is the way things are now. We don't have that available. And it's really hard because we're trying to place people somewhere to live. And when we talk about the sober housing programs, the recovery residences, they have waiting lists. And we tell people the first week they come to us, get on the waiting list now, try to find, get on that and see what happens in a couple months. But we really struggle because we have a hard time just turning people loose who aren't ready with no housing and so on. So a lot of our people, even people that come from out of county, they want to live in Bloomington because the recovery community is so strong, and they connect and find answers here with that community. And now it's time to go home, and they're like, "No, this is where I need to be. This is So we love the recovery community here, but it's really a struggle sometimes when we're trying to help. Even our employees can't afford to live in Bloomington, and here we're trying to help people find a place to live. So, it's crazy. And another thing I want to mention, I had 3 program challenges. The length, another was our preference is to have Monroe County only residents. We don't always fill our beds with Monroe County only, but we prioritize Monroe County. We also prioritize pregnant women, women with dependent children, and IV drug users. Which pretty much everybody, it seems like, is an IV drug user anymore. So it's not really a priority. It's just, it's a given. But we really prioritize Monroe County. But at this point, we would like it to be pretty much Monroe County only. We'd like to just service the community we're in. And other than that, just talking about staffing is an issue. We've had to increase. It's so hard to find clinicians right now, or just tax any staff. And we've had to raise what we're paying for clinical staff by 40% in the last 2 years alone, which is crazy for a small not-for-profit. So, but you can't find people. You can't put an ad out and find anybody willing to even interview unless you really put some money on the table. And it's been really difficult with our budget the last few years, couple years. So, and again, in wrapping up, I just want to point out just a lot of the partners. We could not do what we do without this community and our partners. And, New Leaf, New Life, I mentioned, shout out to them too. Our residents love New Leaf, New Life and get a lot of needs met there. We get a lot of referrals from Centers on CRC. That's one of the places our outreach admissions coordinator coordinator will meet with people there sometimes, and we can take them from there once they've completed programming there. And so many others. IU Health is another resource we use for a lot of our residents and so on. But I listed a bunch of them. Positive Link, Monroe County Probation. I agreed earlier with the comment about, you know, it doesn't matter why people come, if they're court ordered or not. I always like to say, I don't care why you're here. I'm just glad you're here. And really, the key is not where they're at when they come in the doors. It's where they're at like 2 months later. When you see people, it's kind of like going from I gotta be here to I get to be here kind of thing. And there's something spiritual in that happens. You see people change. And I really don't care what brings them in the doors that first day. I just want to see them hopefully, you know, connect and find what they're looking for by the time they're completing treatment programming. So I think that's pretty much all. Just an overview of our programming. So
thanks again for being here and putting this together. It was encouraging to see the number of you put the community partners on there, and a lot of those folks are in this room and doing, you know, or that we deal with on a regular basis. It's kind of cool. That's a lot. It's late and it's a lot. Do you have questions or comments? Okay, do you?
I think it'll suffice to say, I've been taking a lot of notes. The last meeting of this group, which is in 2 meetings, will be to go over all the recommendations. It is really helpful that you two put recommendations, your 2 organizations, excuse me, put recommendations at the very end. And there's just so much overlap between what you're saying and what New Leaf New Life is saying and what the sheriff's department is saying. I think we've got some pretty big challenges, but to your point, I mean, we can do it if we come together. So I think aside from asking a million questions and prolonging this for another hour, I think that's what I'll leave it at.
Yeah, I think that's probably wise. We'll move forward. I'm going to make an executive decision that while we have public comments, we are approving our minutes. All in favor of approving our minutes? Aye.
Aye.
Okay, so now we can get that out of the way. And I do have a list of folks for public comment. If we could limit comments to 2 minutes, that would be very, very helpful. Believe me, I know.
yeah.
You got 1,000 words in that picture right there. No, I understand.
Give us your best.
I really want to hear from you. So if you can. Yes, the list got brought back up here. You can be on the list. Yes. All right. Can I say 3 and then let's do 3. And then please submit written comment. I mean, I know you'll reach out. I know you do. But I don't think I think 3 is what we're gonna do. We Renee, your name is on the list first. TSC, I'm gonna do 3.
This is supposed to be the people's house. This is what that organization's on. This is not the people's house. And I'm offended.
I'm sorry.
So I want to say that. My pronouns are she, they. You hear occasionally from people who thank you for helping them, and think it was worth it. How many people, show of hands, if I can just help one person, here's the one person, it was worth it. Show of hands. Gosh, it was worth it, wasn't it? Wait a minute. You just harmed this many by incarcerating them. So was this one person really worth harming or helping this one person? The answer is no, because you've harmed this many people by incarcerating them. Let's say you hear from this many people that you've helped by your programs, but you've still harmed this many people. The point is we don't hear from people that you've harmed because nobody wants to come and talk to you because you've harmed people. I am one of those that's been harmed by this system. And it's very important that we do not incarcerate and keep incarcerating people. It's harmful. It's a problem. And that was the short of it for the sake of having to shorten things. Thank you, counselors and other people that are here and listening. Incarceration. PICS, post-incarceration syndrome. No matter how you dress it up at the jail, people will come out of jail with PICS. That's a syndrome from being incarcerated. It causes job loss, it causes emotional support loss, it causes housing loss, it causes disruptions to our education. It is difficult to form new relationships once people find out you have had a criminal past because it's stigmatized. Haunting stigmatizations contributes to a myriad of deleterious, harmful states, including isolation and shame. Just sharing one's past is risky, as well as frightening. When you think you were friends with someone and then they disappear after, it is quite telling, and this happens frequently with the very people, some in this room. It's really sad. It's very sad. So who really should feel the shame? The people who abandon the friends when they find out that they've been incarcerated and had problems? Or should it be the people that have actually been incarcerated? I'll let you all figure out who should feel that shame. Ten of the most adverse psychological effects and harm caused by incarceration: depression, paranoia, claustrophobia, delusions, stress, denial, nightmares, substance abuse, increased level of hostility, panic. There's others, like increased likelihood of recidivism, disassociation, emotional and social withdrawal, diminished self-esteem, PTSD. I suffer from all but two of those because of this very system. And no matter how you dress it up, that won't change. The psychological effects can long last past after someone leaves jail, and this underscores the importance of providing people with resources instead of incarceration.
Thank you. Thank you very much for your comments.
Stretch that out a little bit.
Appreciate it.
That was not at all as much as I wanted to say. One person, this is how many you harmed for every one person. And many of you raised your hands, which is scary.
Well, I have Julie Hardesty written down. Are you still here?
Hello, can you hear me? Right. Good evening. I'm Julie Hardesty, a resident of Monroe County. Today, I'm giving public comment as a county council appointed member of the Monroe County Women's Commission. Currently, the Women's Commission's purpose states the commission shall serve in an advisory role to assist residents, businesses, and the government of Monroe County in addressing issues of gender equity in all aspects of society. Regarding today's topic, treatment, construction, and operation, the Women's Commission reviewed findings and guidance from peer-reviewed articles in the fields of correctional health care, mental health, trauma-informed, and gender-diverse care. Based on that research, we recommend the following. For physical spaces in any new jail facilities and now, we agree with the sheriff that we need separate spaces for interviews and therapy sessions that offer quiet and focus away from activity rooms and living spaces. Family-friendly visiting spaces are also needed. Focus on a physical environment that promotes a sense of safety, calm, and de-escalation for inmates and staff, and provide spaces for staff and inmates to practice self-care. For personnel, more positions and more time for qualified licensed therapists to offer evidence-based treatment, as Sheriff Marte mentioned. Case managers to follow up after release, as Sheriff Marte also mentioned. Trauma-informed training for correctional staff and treatment staff that includes transgender patient needs for health, mental health, and safety. And staff should proactively assume that all incarcerated women have experienced past trauma. And for services, use a gender-responsive, validated risk assessment tool that considers each person's trauma histories to measure their unique circumstances and mental health needs, such as WRNA or SPIN-W. Medical screening that is in-depth to identify gender-based needs that are gender-affirming. Time allotted in all inmate schedules to receive treatment and education. Connection to aftercare upon release from jail provides sustainable funding for programs that already exist in our community, such as those at New Leaf and New Life and others that presented here tonight, and incorporate peer support into these services. I'm going to end this with a quote from guidance we read on trauma-informed care by the Substance Abuse and Mental Health Services Administration, which is SAMHSA, that was mentioned by Centerstone. Trauma does not occur in a vacuum. Individual trauma occurs in a context of community, whether the community is defined geographically, virtually, or organizationally. How a community responds to individual trauma sets the foundation for the impact of the traumatic event, experience, and effect. Communities that provide a context of understanding and self-determination may facilitate the healing and recovery process for the individual. Thank you.
Thank you. I've gone through the list of names, so I'm going to move this over here so you can sign in.
Okay.
Nicole Siegel, Bloomington resident, member of Care Not Cages. Thank you so much to this committee for trying to think of how to fund housing, treatment, and social services instead of building a new jail. I appreciate your efforts enormously. This body was formed when the county commissioners tried to foreclose a forum in which public opposition to the jail was highlighted. And it's still an important site of progressive thinking about public funds, harm, and justice. I'm worried, though, that there's nonetheless a slow creep towards a sense of the inevitability of a new jail. This body was formed to resist that creep. And yet there seems to be significant acceptance for the idea of a new jail. I feel that I've missed something somehow. There still has been no estimate for the renovation of the existing facility, despite the Ken Ray's report's recommendation that one be made. The rough projection of a sum has been taken as an actual estimate, though only the higher figure is ever mentioned. The 87 pages of the Eve Hill report's recommendations include no mention of a new jail. Instead, that consultant insists on housing, treatment, and social services, which, if implemented, would increase space by decreasing the number of people in the jail. Have we just discarded that entire report? Its recommendations about the K block in the jail, the mental health block, were just reiterated almost exactly by the sheriff's team. People say the facility is beyond repair, but what exactly is irreparable? Is it the plumbing? Are we sure we can't fix the plumbing? The roof, the locks, the walls, the light? Nobody has ever specified what exactly it is that can't be renovated. I call beef on the claim that the current facility can't be renovated. Today, we heard from the sheriff's team that everything envisioned for the new jail could happen at the existing facility, that the things they need could be incorporated right now. But of course, funding is scarce, as everybody says. So one suggestion, let's get rid of the community courts. Let's just get rid of them entirely. People who bring through these problem-solving courts sometimes call them problem-creating courts. They lead to expanded surveillance and supervision, fees and financial obligations, potential incarceration anyway, years of social control over a person's life. Plus, they don't save money, they don't reduce incarceration, and they exacerbate racial inequality. So let's spend the funds that we allocate to those courts instead on the assistance people need directly outside of the court system. We can do that by closing the community courts and funding housing, treatment, transportation, healthcare, good food, clean water, education, childcare, youth programming, leisure, public space. That would be a better use of county funds and a much better use of individual funds because they're not bogged down with fees and costs, and much more humane than the coercive process those courts make people go through. So that may seem a radical suggestion, but problem-solving courts are recent. I'm a historian. They were added a few decades ago. They're new as a baby. They could as easily be taken away as they were added. But this is just one example of how thinking creatively about how to reroute funds from where they are now to the real needs people have that would keep them out of jail entirely. That, of course, is a far better situation for anybody we consider part of our community. A new jail is an expanded jail. It is a decision to spend limited funds on incarceration instead of everything you know people really need. That development is not inevitable. You have power, use it.
Thank you. Are there any other members of the public here in the room or online who would like to make comment this evening? If you're online, you can go ahead and raise your hand. If you're here and you'd like to make comment, come on up. Okay, seeing none, I will adjourn this meeting. Thank you. Oh, wait, what?
Commissioner
It didn't show, it just showed up. Commissioner Githens?
Yes, I want to thank, first of all, everybody who came tonight, both the public and everybody who presented. And I just wanted to invite everyone to paint the town purple at 5:30 on September the 8th. It'll be on the south side of the courthouse lawn. This is to celebrate those in recovery and to help lower the stigma that we have heard about a lot tonight. So please join us if you get a chance. And again, thank you to everyone.
Thank you. Good reminder. And now we are adjourned.
Thank you, PSD.
Well, I'm going to make